the induction, what in India are we concerned about? We are concerned about prolongation in cytopenia and increased risk of induction mortality. Now, with the midostaurin story, thankfully, that's not there. With adding midostaurin, there was no difference in the ANC and the platelet recovery time in the randomized control trial. So the next question is, if you add on these drugs, can you take away transplant? Not really. Even if you look at patients who had midostaurin, the transplant improved the outcome in that group of FLT3 ITD as shown by the top curve compared to the patients who did not get transplant and were in CR1, even in the midostaurin arm. And these are broad strokes, but broadly applied to most of the small molecules. If you look at alternative and intensified induction, and this is an old story of 90 milligrams per meter squared versus 60 milligrams, that has for the most part been set aside, and most people use anthracycline at 60 milligrams per meter squared based on the UK and the SWOG data, and that's what we will go with. There is a small story about 90 milligrams per meter squared being beneficial in patients with FLT3 ITD, but in India, for the most part, none of us are going this. And this is a problem with high-level, high-quality evidence and the real world. This is the AML-15 trial. You can't get a better randomized phase 3 control trial. And if you follow this trial in detail, the best algorithm or the best route was to go flag-IDA, followed by 1.5 grams per liter cytosine. And with that, you get the best long-term survival. In fact, in the co-binding factor leukemias, you hit an incredible 95% survival. Who in the world is using this regularly? With the exception of MD Anderson, a few centers in the US, nobody. No one in India will go with flag-IDA. So this is the disconnect between high-level evidence and you know your ground reality of what you can actually take your patients through. So this we must always remember when you read literature. When you look at BCL2 inhibition in the context of intensive therapy, for the students out there, BCL2 inhibitors like venetoclax are essentially like the terminal activation complex of the complement. The backs and the back bind on the surface instead of the cell membrane, they bind on the mitochondrial membrane and form pores. In a normal situation, the backs and back are segregated or sequestered by BCL2 and other anti-apoptotic proteins. When you block that sequestration, backs and back dimerize and form these pores through which material leaks out and the mitochondrial dissipation and disruption happens. This is a crowded slide. The only objective is to say that people have used flag-IDA plus venetoclax in relapsed refractory and newly diagnosed early phase trials and showed fantastic results. Our own experience with flag-IDA and venetoclax is be ready for very long cytopenia, long time to recover, and significant amount of morbidity and to some extent mortality. So be cautious when you see these early phase data. This is the data from China using 3/7 plus venetoclax for 7 days. Just going to highlight a few points. Almost 60% of the patients in this trial were good risk. That's very unusual. And if you look at deaths, 0 induction deaths in all these patients who got 7/3 and 7. And if you look at the ANC recovery, all were within 19 days. In our center, even with 7/3, we don't get ANC recovery in 19 days. So there are a lot of aberrations here. So when things look very exciting and very good, of course, survivals are fantastic. I think it's good to be cautious and always, always look at your own center's data. That is your reference point. Azaven, I call it the rise in the rise. Everybody's using Azaven, and it's actually a trend where it's very difficult to define what is unfit, and no two physicians will agree what is unfit. And you have increasingly young patients getting Azaven in India today, one for the cost factor, but the big problem is people are often not clear what is the big picture. Okay, after 1-2 cycles of Azaven, what do I do? Do I transplant? Do I do hydrocytosis? When do I do this? These algorithms are totally not clear. So we're often jumping the gun with approvals that have come in elderly AML. We're straight away taking it to young, fit adults. So this is a case that I just illustrate. A 48-year-old man in intermediate risk AML, and cytogenetics normal, and NPM1 and IDH1 are mutated. I say that specifically because these are 2 mutations where the drug works specifically well with a high count, high LDH, and high uric acid. And the performance state, again, this is often a debate, as I said, and in any multi-consultant group, you will have debates of whether he should get 7/3 or whether he should get an Azaven therapy. But remember, this particular patient with those parameters that I showed you has a high risk of tumor lysis syndrome. It's unusual in AML, but you need to look out for these people who have high counts, high uric acid, a high creatinine, and an NPM1 and IDH1 mutated. When you assess response, this has implications at the start of therapy. It doesn't go like an ALL, bang, bang, bang on time. You have to be very careful because you can get very prolonged cytopenia and you need to know how to handle it. It's a crowded slide again, but basically between 21 and 28 days of the first cycle, we tend to err on 21, and the reason we do that is on 21 days you can get two broad extremes. One is cellular marrow with blasts, in which case you immediately come on day 28 with the full doses. The other extreme is you can get a very hypercellular marrow with minimal blasts or no blasts, in which case you give growth factors and you wait for some amount of recovery before you give the next cycle, potentially with reduced doses or duration. And I refer you to this slide for greater details in terms of the guidelines. Liberal use of GCSF. With hepatic failure, for the most part, unless it's very severe Child-Pugh-C, you can use the drug. Renal GFR, even more than 30 ml per minute, you can use the drug. What can you expect? This is a crowded slide, and I just want to take home the CR. And often when you read these studies, they talk about overall response rates, and they all sound fantastic. But that's a mixed bag. In your conventional CR, what are you expecting? You are looking at a CR of 30 to 40% at the end of 3 to 4 cycles, and of that, you are looking at only 30% who are, by conventional definition, MRD negative, with a median time to response of 1.3 months. Having said that, the combination of hypermethylating agents and azaven has really improved our ability to treat patients who we would have otherwise normally not been able to give any kind of therapy. When you say MRD negative with azaven, with aza-7, this is just a cartoon to illustrate my concept. This is not the truth. But the whole MRD negative is a big, dark well below the surface. We really don't know where exactly in that MRD negative a person is lying. So conceptually, the MRD negative could all be much higher with azaven versus 7-3. And we know that the depth of remission has significant impact on survival. Allogeneic stem cell transplant, I still believe, is the most important and central role in the long-term management of AML. And as I said, it's an expert opinion. If it's indicated if the risk of relapse is greater than 40%. With the exception of that good risk group of patients, you can take WHO, EL, and ICC, where you will not transplant in CR1. Everybody else, you will offer transplant. So we do a fair amount of transplants at CMC, 310, 20% of our transplants are AML, and our long-term data will tell you this is very mature data, and I can tell you compared to chemotherapy, truly long-term survival in AML is seen in CR1. This data has a lot of caveats, a lot of selection biases of people who get to transplant, etc. But having said all that, young fit patients should be given a chance at induction intensive therapy followed by an allogeneic transplant in CR1. And we've challenged the necessity for a myeloablative. It's a huge debate, should we use myeloablative? Our own data comparing 170 patients with Flu-Mel, which is reduced toxicity conditioning, and Flu-Bu, 185 patients. Without getting into the details, we see no difference in our outcomes. In our country, we would push for a reduced toxicity conditioning in CR1. MRD is an evolving field. For the most part, pre-transplant, we know that it has a poor outcome. If you're MRD positive. In fact, it's a terrible outcome, as I'll show you a little later, but we don't know how to intervene based on the MRD. So in the ELN this time, there is a concept note, which is not definitive, that if you are MRD positive or you have a less than 4 log reduction for NPM1 and co-binding factor leukemia, you would actually consider transplant in CR1 and therefore push them into a higher grade. For the higher grades, it's not really clear what you do. And this is the data that illustrates it. This is the original French data. If you are NPM1 positive and you had a less than 4 log reduction at the end of induction, that is your survival without transplant. But with transplant, your survival is as good as with conventional, as comparable to those who did not achieve a less than 4 log 1. This is a bit of a scary data. The blue line is people who are MRD negative and are taken for transplant. The yellow and the dotted lines are patients who had frank disease, and the other group who were by conventional definition in CR, but were MRD positive. There's actually no difference in the outcome of those who are MRD negative, but who are so-called CR. How do we intervene with them? That's again is a story that we don't understand. The azacitidine story has gained a lot of milestones with that particular one study. But again, remember that is a one study in elderly patients. It cannot be extrapolated around for all patients. And what we know is that the sorafenib data post-transplant is actually quite interesting. Just going into the SORMAIN trial data to show that there was a significant advance in terms of event-free survival and overall survival, but we are still not utilizing it because there are many challenges, and that's a discussion by itself. So NGS diagnosis is here to stay for the most part. Gemtuzumab probably a role in induction CBF-AML. target therapy is a work in progress. Regional relevance is limited. Increased use of hypomethylating agents when some with concerns. We do need our own data. And also remember, all the classification, MRD-driven data on how to intervene is based on intensive therapy, not based on hypomethylating agent when specific data. Allogenic transplant, I still feel, is the cornerstone of AML management in CR1 for the most part. Multiple retrospective studies show comparison between MUD and haplo. I could have shown you our own data, which is equally comparable. Pre-transplant MRD has significant prognostic factor. Beyond this, it's an evolving story as the post-transplant maintenance therapy. I'll stop here, acknowledge all my colleagues, my funding agencies, and people in the labs who work with you. Thank you for your attention, and hope to welcome you to our new center at any time that you are around in Vellore.
That was, as usual, a great presentation. You flipped through so many details in a short span of time. I think you covered many aspects. There may be a lot of questions in the audience, in the youngsters' mind, because AML is such a disease which looks easy to manage, but is one of the most distressing for the treating physician. By the time I think I can see some hands coming up. Vikram, the problem remains, the most scary thing is the good risk AML who has achieved some remission, and our cytogenetics has been inadequate because of the outsourced labs. So my problem is actually, we all must be seeing it, the good risk patient in remission and CR1, and we don't transplant this patient, and sometime later these patients come back with relapse. So this thought has always been brought up again and again that in India, best time is CR1. So when you have the problem in your MRD problem with, you don't have the NGS available to you, reliable NGS available to you, should you, if patient is fit enough in CR1, young patient, would you leave him alone because there's no point giving maintenance to such a patient, or do a transplant in CR1? And the second thing about the FLT3, because it is to be considered as intermediate because of the midostaurin and related agents. If they are not available, should these patients also be taken up for the transplant?
I'll start with the second one. I'm very clear that all intermediate risk and high risk should be taken up for transplant in CR1. So FLT3 ITD, we would certainly consider transplant in CR1. For the first question, our own data with good risk co-binding factor leukemia, specifically leaving the APL out and leaving the CBP where we don't have enough data, would not really suggest that the outcomes are worse with just chemotherapy. For the patients who relapse, they do relapse. But if you want to look at a subset that may not do well, you can look at the old German entrenched data. For patients who present with co-binding factor leukemia with very high counts, actually may not do so well. But having said that, there's no clear guidelines, therefore this is the group where you would transplant in CR1. If you did have MRD, the NGS doesn't really matter because for the most part, co-binding factor leukemias are dominant good risk factors. The MRD, if you had, would be something that would be useful, both in the NPM1 setting and the co-binding factor leukemias. If you don't have that, I would find it difficult to justify transplant in CR1.
Thank you very much for a very nice presentation. My compliments for finishing in 15 minutes and 6 seconds. So lovely listening to you. And I can see that you didn't mention WHO5. You went by ICC and ELN. So I don't know which way the wind is blowing in Bharat. Is it WHO5 or ICC? But I guess there is hardly any difference between the two.
Thank you, Vikram. I think the time is over, so may I request Dr. Bakul to invite the next speaker.
I'm delighted to introduce to you a PGI alumni, Professor Gautam Bor Thakur, from the Department of Leukemia in Houston, MD Anderson Cancer Center in the oil city of Houston. He is head of one of the units there, and his main area of interest is in adult acute myeloid leukemia, mainly the drug development, the epigenetic targets, MAPK targets, and in the autophagy. So, Dr. Borthakur.
Thank you very much. Hi, it's always a great pleasure to come to your alma mater. It's a matter of pride to come here. Now that's the problem that Vikram created for me by being on time. So I'll see what I can do. I might have to skip over some of the slides, but that's okay. All right. So I'm trying to put in a conceptual framework, and then I'll try to go to a more practical, what can be done. The conceptual framework is that the AML resistance can be either cell intrinsic or cell extrinsic. So cell intrinsic pathways could be either apoptosis resistance as upregulation of MCL1, BCL-XL, kinase mutations that are emerging, like mostly MAP kinase mutations, rewiring of the metabolism of the AML stem cell level, mostly around the fatty acid oxidation, and then there are epigenetic changes that happen, because AML of all is possibly, in a broad way, is an epigenetic disease. Most of the mutations that happen in AML are epigenetic mutations. Now if you come to the cell extrinsic part, then there are things like that you can come to the addition molecules, which include E-selectin CXCR4, mitochondrial transfer from the stroma to the AML cell to supplement metabolism. So these are the conceptual framework. The question is what is more doable, what we can do now. One is, of course, MRD elimination. Vikram had already alluded to that. I'll possibly use FLT3 AML as the paradigm for that. And the second thing is also our knowledge of understanding biology. If we understand biology, then maybe we can come up with better treatments, and also to target the escape mechanisms at the same time. And in this context, I'll use the paradigm of MAPK mutation. And finally, the question of can you disrupt the AML at the stem cell level, the particular stem cell fitness, but that's something that I'm not going to allude to because that's still a work in progress. So core binding factor, again, it's a good risk. AML is one of the diseases very close to my heart. So what we had shown, we had used fludarabine Ara-C GCSF-based regimen with Mylotarg. And when Mylotarg went off patent in US, actually is off, not approved for a period of time, at that time we actually used idarubicin as a replacement for the Mylotarg. Now, in that context, if you see on the left that the flag and Mylotarg or gemtuzumab-based regimen had yielded much better outcome. But what really mattered, if you focus on the right on the yellow highlights, are actually MRD elimination. The early MRD elimination, even after cycle 1, is predictive of long-term outcome. So as I said, I'll possibly stick to the FLT3 mutation paradigm. As you know, the FLT3 mutations, primarily two kinds of mutations happen. One is a mutation in the juxtamembrane domain, which is a tandem duplication, and then other mutations, more point mutations that happen in the kinase domain. It happens in about 25% of all AML. There are two different kinds of inhibitors are available, broadly type 1, type 2. Type 1 can bind to the active conformation of the ATP pocket, so it can hit both the ITD as well as the point mutation, whereas the type 2 inhibitors can only hit the ITD only. So quizartinib is a type 2 inhibitor, which is a very potent type 2 inhibitor, and based on this data, this is approved now that there is a frontline combination of 3+7 with a FLT3 inhibitor. So if you have a target and it can potentially deliver a concomitant target suppression, then there is definite improvement in outcome. The second thing is the Soramain data that Vikram had indicated. So in a FLT3 mutated context also, if you kind of suppress the target, ongoing suppression of the target, even post-transplant, can actually result in a better outcome. So there's either a concomitant target suppression or a continued target suppression. Now finally, in the context of FLT3 suppression, gilteritinib is in this context of type 1 inhibitor. It can hit both the ITD and the point mutation. But when you look at who benefits from adding gilteritinib, say post-transplant maintenance, the people who benefit are the people who are actually MRD positive. The folks who are MRD negative by a good quality assay can potentially not be maintained with a FLT3 inhibitor. So there is a population who may not need a post-transplant TKI for that matter. Then the question is, can we potentiate FLT3 inhibition upfront itself so that you can get a better MRD clearance? So one thing that you can do is actually when you combine venetoclax, which is a BCL2 inhibitors, with FLT3 in the lab, there is a significant survival in the mouse. And so the doublet works, right? Then the question is, can you do triplets? So I had to give salute to Bachchan Saab. So I had to bring in this triplet of azacitidine or a hypomethylating agent, a FLT3 inhibitor, and venetoclax. Now, delivering triplet therapy is not easy. It's very easy to suggest that, these are all low-intensity treatments, you can deliver this, but the cytopenias are a big risk factor, and that has to be looked into because, and it needs certain amount of, oncologic art to deliver that too. But on the other hand, if you look at the responses, even in a frontline setting, a very high rate of true CRs, of course. In the relapse refractory setting, we're getting more of myeloid, bone marrow clearance. But that's not a bad outcome to have because if you can take these patients to transplant, so at least, it gives these patients an option. On the left, we have MRD clearance by flow, and on the right, we have MRD clearance by a not so sensitive PCR assay. The same concept actually you can potentiate IDH inhibitors also with BCL2 inhibition because the cells that carry IDH1 or IDH2 mutations, they have this neometabolite called 2-hydroxyglutarate. So 2-HG suppresses cytochrome oxidase, and so the level of cytochrome C in the cells that carry IDH1, IDH2 mutations are much higher. So they're sort of poised to die. So they need a little bit of a push, and that push is possibly delivered by venetoclax. So in the IDH mutant patients, the long-term better outcome with IDH1-2 inhibitors are the patients who actually clear the mutation. So maybe combining IDH1-2 inhibitors with venetoclax plus a hypomethylating agent, you can deliver a deeper response. Now, the question is, can we target kinase mutations? Coming back to the FLT3 mutant story. On the right, we have a story about quizartinib, which is a type 2 inhibitor. So it hits FLT3 ITD alone. And it hits FLT3 ITD very potently. So the escape mechanisms in this are either FLT3 point mutation or MAP kinase mutation, like NRAS mutations. On the left side, you have gilteritinib, which is type 1 inhibitor. So it inhibits both the ITD and the point mutation. So here, the escape mechanisms are more based on mutations in a non-FLT3 pathway, which is a RAS pathway or IDH1 pathway. So it's a very polyclonal disease in that sense. As under the pressure of treatment, then AML becomes somewhat of a more polyclonal disease. And resistance also would depend on what kind of inhibition you're using. The same MAP kinase emergence is also not necessary only for FLT3 mutated patients alone. This also happens in the patients with azacitidine and venetoclax-based treatments. The patients who kind of either relapse or do not achieve remission, most of them also carry a MAP kinase mutation. So the MAP kinase pathway, it's a RAS, RAF, MEK, ERK pathway. We decided to kind of focus in the lab, at least in the terminal part of the ERK pathway. And there's this very talented postdoc, Priyanka, who's been working with me for a while. And what she has shown that when you combine venetoclax with ERK inhibitor, the terminal pathway of the MAP kinase pathway inhibitor, then actually you improve outcome. And we're going to do the same Amar Anthony story with an ERK inhibitor in the clinical space, and the trial just got approved. So finally, we also need to understand biology, and again, this is very critical, particularly in the development of menin inhibitors, which is one of the bigger stories in the AML field right now. So MLL fusion, the MLL gene can have multiple fusion partners, right? But in all these complexes, menin is recruited, and recruitment of menin is necessary for the structure of the transcription complex to take place. And the idea is if you can disrupt the interaction between MLL and menin, then the downstream pathway of genes, like the Hox gene pathway or the mice family of genes, these are the genes, when they're overexpressed, they cause differentiation block. So, these are causative they're pathogenic in MLL rearranged AML. So if you use a menin inhibitor, which kind of disrupts the interaction between menin and MLL, then you are suppressing the expression of Hox or mice genes, and these cells actually undergo differentiation. And this you see clinically very, very early on, within couple of weeks of menin inhibition, you see substantial rise in white cells, and even to the extent that you have differentiation syndrome problems like we have in some patients with APL. And then, of course, the resistances still happen. And many of the resistances, particularly to the menin pathway, has been happening by mutations that actually block the interaction of menin, the drugs that are targeting the menin-MLL interaction into that binding pocket. And these drugs can not actually bind to this pocket, and that's why many of these mutations that are emerging as resistance mutations. So in this context, as you see, possibly MAP kinase pathway mutations are not playing a resistance pathway, unlike the kinase mutations, say FLT3 pathway. The emergence of MAP kinase mutations are a substantial part of resistance, whereas not in the context of menin inhibition. Actually, I can possibly finish on time. Maybe I can beat Bikram there. So, again, overcoming resistance is it's a multifaceted issue, right? And you can achieve by achieving deeper responses by continued kinase inhibition and elimination of minimal residual disease, particularly in the situation of core binding factor, APL, etc. These are very well established paradigms. And also possibly in the context of NPM1. Again, if you do a very good MRD elimination in patients with core binding factor, AML, or NPM1 mutated AML, you know a group of patients who do not need transplant. On the flip side, you can also identify a group of patients who will possibly benefit from transplant too. Understanding disease biology is very critical, as we had seen in the case of menin inhibition. Now we have an oral drug that actually gives about a 30% of response rate for these patients who otherwise would not have a chance to even go for a transplant. It's an oral drug, single agent. So targeting escape mechanisms, the MAP kinase mutation have been identified both in the solid tumor as well as in the leukemia space for a long, long time. The drugs have not quite delivered so far. We will see whether the new inhibitors, particularly the ERK1, ERK2 inhibitors, deliver the promise. And finally, the question is there a way that we can disrupt the fitness of these AML stem cells? Some of the fitnesses also come from the mitochondrial evolution in the AML cell, particularly the rewiring of their metabolism. And that is something that we can possibly talk at a later time. If you guys call me back at some time, we can talk maybe next year. We'll have a little better story ready there. Thank you very much. I'll be happy to take questions.
Thank you very much, Professor Thakur. You get the award for finishing before time.
This is the first time I've done that. So.
That's right. The presentation is open for questions.
So one of the things actually, again, coming to the context of the resource constraint situation, right? A new story is emerging, right? Because hypomethylating agents are becoming oral agents now. So now can you do a total AML therapy based on oral agents only and not subjecting the patient for a long-term hospitalization? So that's becoming more and more of a reality. So, once these drugs are approved and can be at least, you can get biological similars, then you can potentially think of AML therapy as an oral agent, which possibly 10 years back we could not have imagined.
Dr. Srinivasan.
Although I don't work in this field, it's a philosophical question for you. We always inhibition. We're looking at mutations, activating mutations, and we're looking in the lab for inhibitors. Can you do the reverse? Look for actors. We dismiss non-targetable, you see?
Right.
But has anyone even tried looking at them as targets potential?
Right. In that context, actually, conceptually, you can take the epigenetic drugs as that way. That some of the, many of the epigenetic drugs, we really don't know how they work. Like, say, hypomethylating agents. The question is, are we actually activating the tumor suppressors by using the hypomethylating agents, right? Because if many of the tumor suppressors are hypermethylated and they are suppressed. and they are not expressed. So you're re-expressing them by using hypomethylating agent. So in the kinase context, it's a little difficult, but in epigenetic context, it's possibly more doable.
Thank you for that talk. In one of your slides, you had mentioned about response rates to aza-ven. So just out of curiosity, when do you assess response? Because these are oral molecules, they may take longer to act. So what is the time point at which you assess response and by what method?
If you use aza-ven, particularly if you're using 21 to 28 days venetoclax, you can pretty much assess response at the end of the cycle. Now again, that's where the trick comes in, that does every patient need a 28-day of venetoclax? Possibly not. Because many patients you can possibly get away by doing 14 days of venetoclax and avoid the long-standing neutropenia. And particularly these neutropenias are also much more, in patients when we use 3-drug regimens, the triplets. They're catchy, they're attractive, but delivering it's a bit of an art. So, again, doing early marrows to see what the response is, they do a day 14, day 21 marrow and stop treatment.
Thank you very much.
How, just one.
Okay,
how
one
early can
quick
we
follow-up
expect
question.
a response with aza-ven?
I'm sorry?
How quickly can we expect a response with aza-ven?
Between 1 to 3 cycles possibly, yeah. You get the best idea.
Thank you very much. Thank you very much for the lively discussion. Professor Bo Thakur, thank you very much for coming in. And Drs. Matthews and Dr. Subramanian, it was a delightful, entertaining, and academically superb, high-quality discussion. Thank you very much. We close this session now, and the host will now continue.
Yeah, good afternoon, everyone. Previous talk in the session, AML recent updates in diagnosis and classification, it was sponsored by MedGenome. Now we are going to start the next talk, which is updates in myeloproliferative neoplasm and myelodysplastic neoplasms. I would like to invite Dr. Ajay Sharma to chair this session. Dr. Brigadier Ajay Sharma, he is Senior Consultant in Department of Clinical Hematology, Sir Gangaram Hospital, New Delhi. His area of interest is bone marrow transplant. He has done his fellowship in hematology research, National Institute of Health, USA, and he has authored various papers and co-authored various other papers. Next, our chairperson is Professor Bakul Dalal. He is already on the dais. He is MD Pathology from PGI Chandigarh, and he is clinical professor in University of British Columbia. And his areas of interest are hematology and flow cytometry. And he is director chief editor of PGI textbook of clinical laboratory and hematology. And he has contributed in more than 100 papers, chapters, abstracts, and has won several awards. Now, next, I would like to invite Dr. Anita Tehlan, ma'am, to chair the session. She is professor in Department of Pathology from GMCH Chandigarh. Her areas of interest are nutritional anemia, hemolytic anemia, molecular oncology, and laboratory management. And we have 4 talks in this session. The second talk, Managing Anemia in MDS, is being sponsored by Bristol Myers Squibb. And the last talk, CML Unmet Need and Treatment Landscape, is being sponsored by Novartis. So please, I request you to chair the session.
Thank you very much. I would like to now first invite Dr. Jasmita. Dr. Jasmita is a hematopathologist in the Department of Hematology at the All India Institute of Medical Sciences. And her areas of academic interest are coagulation and flow cytometry. And she will talk to us today on myeloproliferative and, myeloproliferative neoplasms. Dr. Jasmita.
Thank you, chairpersons. And at the outset, I would like to thank the entire organizing committee for having invited me here. It is a beautiful city, and the conference is an academic feast that we are all taking. So I am going to talk to you about the recent updates in diagnosis and classification, and my presentation is primarily targeted towards postgraduates. So we all saw that in 2022, we got two classifications, the ICC and the WHO. As far as MPNs are concerned, both the classifications are fairly similar, and the change is highlighted in blue in the WHO classification. So if you have a look here, JMML is included in MPNs in the WHO classification, while it is included in pediatric tumors and germline predisposition syndromes in the ICC classification. In addition, in doing with the theme of WHO, unclassifiable has been replaced by not otherwise specified. So MPN unclassifiable remains MPN not otherwise specified in the WHO classification. Other categories of MPN remain fairly similar. So if you remember Mani sir's talk also, the gene fusion symbols have changed, and these were the points against the hyphen and the slash being used as separator, and they follow the ISCN recommendation for using a single colon to denote a break and double colons to denote break and fusion. So for chronic myeloid leukemia, the key change in the WHO classification is the omission of accelerated phase. So it retains chronic and blast phase, while ICC retains the three phases, chronic, accelerated, and blast phase. And what it does to us when we are reporting out cases is that there is a chunk of patients who have blasts which are over 10% or who have basophils of over 20%, and we still have to call them chronic phase as per the WHO classification. So as far as the definition of blast phase is concerned, it is similar in both the classifications vis-a-vis the presence of myeloid sarcoma or the bone marrow or peripheral blood blasts, which have to be over 20% or equal to 20%. However, now the WHO classification as well as the ICC recognize the importance of lymphoblasts, and it has been put in the part of the diagnostic criteria. So here in the ICC, they say morphologically apparent lymphoblasts of over 5% and immunophenotypic verification of a lymphoblastic crisis has to be considered, while here it is bona fide lymphoblasts in the peripheral blood or marrow, even if they are less than 10%. Now, practical consideration again comes in how many of these samples should we be flowing to look at whether they have lymphoblasts or not. For all practical purposes, any high-risk chronic phase or any patient who is in accelerated phase or blast phase, we will flow. Now, with respect to the accelerated phase, again, these three criteria, which were the rising TLC, splenomegaly, or thrombocytosis or thrombocytopenia, they have been omitted in the ICC classification, which retains the entity of accelerated phase. The major root additional chromosomal anomalies are included as a diagnostic criteria here. However, the WHO definition, as I said, recognizes high-risk chronic phase, which can be either diagnosed, which can be either present at diagnosis, or it can emerge while a patient is on therapy. So for the criteria, the three criteria of blasts, basophils, and ACAs remain. In addition, a patient who has a high ELT score is at a higher, can be called a high-risk chronic phase. And if they have small megs, along with fibrosis, clustering of megakaryocytes on the biopsy, that also is a feature. Now, the WHO 2016 had a category of provisional response criteria to TKI. So these were provisional, and now they have been included as high-risk chronic phase while the disease is going on. That is failure to achieve response to a TKI, any resistance to two sequential TKIs, occurrence of compound mutations, or again, ACAs. Now, with respect to polycythemia vera, if we look at both the classifications, they are fairly similar again. It is just that the point number 2 and 3 are reversed. So for polycythemia vera, bone marrow biopsy showing pan-myelosis is point number 3 in the major criteria. And for a diagnosis, you require either all 3 major or first 2 major and 1 minor criteria. And the reason for including this as the third criteria was that with exon 12 mutations, you may not have panmyelosis. The footnotes of the ICC classification are very interesting because they tell you that for JAK2, we have to shift our assay technology. They want to target a sensitivity of less than 1%, which is achieved either by QRT-PCR or by ddPCR or by a very sensitive NGS assay. And they clearly state that if a patient is negative for JAK2 exon 14, that is a V617F mutation, the other atypical translocations need to be looked for. Now, in the WHO classification, JAK2 is the third criteria, and again, the same factors are there. All three major, or the first two major, and the minor criteria are required. In addition to that, it suggests that for men, the cutoff for doing bone marrow may be 52% of hematocrit rather than 49%. And in addition to that, the red cell mass determination is only to be done, it is not recommended for routine clinical use. Now, I think all of us post WHO 2016 have observed a marked increase in the number of marrows that happen for polycythemia, and very frequently these patients do not really have polycythemia vera, and there is a consideration that they should be investigated for congenital erythrocytosis in addition to suspecting this. Now, post-PV myelofibrosis criteria from WHO 2016 to WHO 2022 and to ICC have seen no particular change. For essential thrombocythemia, again, the criteria haven't changed from the WHO 2016 to 2022 or the ICC criteria, except for a recognition again in the ICC that is clearly stated and given in the text of the WHO classification as well, that earlier we were looking at 3 or more than 3 megakaryocytes lying adjacent to each other as a hallmark of prefibrotic MF rather than essential thrombocythemia. However, this kind of clustering is observed in ET fairly frequently, even in our experience. So therefore, any large cluster, which is now defined as 6 or more than 6 megakaryocytes, is required for you to think of prefibrotic MF rather than ET. In addition to that, again, for the JAK2, sensitivity level of less than 1%, for CALR and MPL, sensitivity of 1 to 3% has to be targeted. And in negative cases, non-canonical JAK2 and MPL mutations need to be looked for. So this was the particular change in the ET classification. For post-ET myelofibrosis, again, there have been no changes in the criteria. It is worthwhile to note that for post-ET post-PV myelofibrosis, elevated LDH level was not a part of the additional criteria, while for post-ET myelofibrosis, which is rarely, ET is rarely associated with elevated LDH levels. So therefore, the additional criteria include the elevated LDH level as well. For prefibrotic and early primary myelofibrosis, again, the criteria as such haven't changed. It is just that the WHO classification includes leukoerythroblastosis here, while the earlier WHO classification did not have it. Leukoerythroblastosis is not present in the ICC classification as well. So again, it is the clustering of megakaryocytes and the megakaryocytic atypia which is highlighted. In addition to that, we have to look at the age-adjusted increase in the bone marrow cellularity, predominantly a granulocytic proliferation and often accompanied by reduced erythropoiesis as a part of the morphological feature assessment. Now, in addition, we have to, in at least primary myelofibrosis, be subjecting our patients to the additional NGS panels for the myeloid genes, because if they are triple negative, then presence of any of these usual myeloid markers, myeloid mutations, can also give you a pattern of clonality. In addition, these mutations, many of these mutations such as ASXL1 or EZH2, SRSF2, and in fact, the U2, A1 also, they all form the high-risk mutation score, form a component of the high-risk mutations, and they are included in the GIPSS and the MIPSS version 1 and version 2 for risk assessment in primary myelofibrosis. And the incidence of these mutations will increase as a patient progresses to the overt fibrotic phase. Again, the criteria for the overt fibrotic phase, they remain the same. They haven't changed. Again, the recommendation of using more sensitive assays. Both the WHO and the ICC classification in their riders acknowledge that you can have primary myelofibrosis with monocytosis, and to distinguish these patients from chronic myelomonocytic leukemia, if we have a MPN driver mutation, that is presence of JAK2, CALR or MPL mutation, a diagnosis of fibrotic PMF should be favored over chronic myelomonocytic leukemia. For chronic neutrophilic leukemia, it was noticed, and this was included in the WHO 2016, that you can have the CSF3RT618I mutation. In addition to that, now they recognize that there can be other activating CSF3R mutations, and the ICC has suggested that if these mutations are present, the cutoff can be lowered from 25,000 to 13,000 for a diagnosis of chronic neutrophilic leukemia, while WHO retains the cutoff of 25,000 regardless of the presence of mutations or not. And chronic neutrophilic leukemia does not do very well. These patients have a poor prognosis, and in addition, we should be testing them for the other myeloid mutations because they are frequently present in this subgroup. Now, for chronic eosinophilic leukemia, both the classifications, they recognize that eosinophilia should be more than 1,500. In addition, the ICC classification says that the eosinophils should be more than 10% of the differential. With respect to the addition and the change, earlier the evidence of clonality was required, or you could have more than 2% blasts in the peripheral blood and more than 5% blasts in the bone marrow. However, very few patients could be diagnosed as CMML based on the blast criteria. So therefore, now the abnormal bone marrow morphology and primarily the dysplastic megakaryocytes or with significant fibrosis is the criteria that is taken into account. In addition to that, it has to be a robust exclusion of the other myeloid or lymphoid neoplasms which can be associated with eosinophilia. And the persistent eosinophilia definition has been changed from 6 months to 4 weeks because many of these eosinophilia patients have organ damage. So rather than waiting for 6 months, it is better to diagnose and treat them earlier. Now, it is both the classifications again acknowledge that when we are trying to establish clonality, any VAF of less than 2% should not be taken as a marker for clonality. It is preferable that in this population, because of the older age, there will be CHIP that may be associated. So if the VAFs are higher, it is probably better, but exactly no cutoffs have been clearly decided. Again, as I said, exclusion of all these disorders is mandatory. Now coming on to JMML, as I said, only the WHO classification includes it in the myeloproliferative neoplasm, and they recognize that it is a rasopathy, so the genetic criteria are important and only one of the criteria can be sufficient. So this can be the mutation in the classical RAS pathway genes, heterozygous mutations of PTPN11, KRAS, NRAS, or if you have clonal somatic or germline NF1 mutation on one of the alleles and loss of heterozygosity, or you have a compound heterozygosity of the NF1 gene. For the CBL gene, again, the somatic and germline mutations along with loss of heterozygosity are mentioned. Now, the change from the WHO 2016 is that they recognize that there can be some fusions which can be responsible for JMML as well, and they have been included in the genetic criteria. For the cases where genetic testing cannot be done or is negative, 2 of the following criteria can be used, and these criteria are again nearly the same as far as the classification is concerned. So this is how the RAS pathway is implicated in JMML with CBL, PTPN11, KRAS, NRAS, and NF1 all being here. For the ICC classification, it recognizes JMML only when it meets the clinical and hematological criteria, of which in the WHO there was in addition absence of KMT2A rearrangements. For genetic studies, it is the first component which is recognized as JMML. For JMML-like neoplasms, if you have any of the fusions of ALK or ROS, they fall in the JMML-like neoplasms. So MPN unclassifiable versus MPN NOS, this entity has been kept primarily to take care of those cases which are very early myeloproliferative neoplasms or which have splanchnic vein thrombosis and maybe due to dilutional effects they are not meeting the exact cutoffs, or patients who have a very aggressive or a late stage disease. So essentially what we want is that a clinical or hematological feature of MPN should be present. There should be a robust exclusion of every other disorder which can have the similar findings, which will include all your myeloid lymphoid neoplasms with eosinophilia, CML, MDS, MPN, and MPNs, along with the presence of a driver mutation or any other clonal marker. So WHO in addition states that if there is insufficient clinical data or if the bone marrow is not sufficient or if there is a recent history of cytotoxic or growth factor therapy, then we should be very careful of diagnosing a patient as MPN NOS. The WHO hasn't really included this in the classification, but alludes to it during the text, that there is a recognition of germline predisposition of MPN, and of this, the high penetrance is for familial predisposition in the duplication of chromosome 14q32, while there are the GWAS data that revealed TERT, MECOM, and the JAK240 and the earlier recognized JAK246/1 haplotype, they have a relatively lower frequency. Now with that, I would like to end my talk and acknowledge my colleagues, Dr. Ganesh, Dr. Richa, one of my SRs, Dr. Vandana Puri, and Professor Mahapatra, who are essentially working while I'm here. Ganesh is obviously here, but Richa is the one because of whom we were both able to travel. Thank you.
Thank you very much, Dr. Jasmita. That was a very rapid enunciation of a very complex and confusing differentiation. Just a question, what does AIMS follow, WHO5 or ICC?
So primarily the WHO5. For us, so for example, if I have a patient who otherwise fits into CML in accelerated phase as per the ICCA, I would mention both the entities. So he is a high-risk chronic phase as per the WHO, while he would fall into the ICC, while he would fall into accelerated phase as per the ICC. For most other categories, if you look at the diagnosis, by far ICC and WHO, they are fairly similar.
They are similar in about 95% of instances, yeah. Back in Vancouver, we give both diagnoses when they are different, and let the clinicians decide what he wants to do, right? Why take the blame? And this presentation is open for discussion and questions. Yes, Dr. Rastogi.
Hello, yeah. So I just have a quick question. Are we doing flow in all cases of CML just to rule out lymphoblast?
No, I am not. It is not practical for our scenario. So therefore, any patient who has a high-risk chronic feature, so high-risk chronic features have been defined by WHO. It was not included in the paper, but it has come in the WHO provisional text that is available. So if there is a high-risk feature, then only these patients should be subjected to flow, in my opinion.
Okay, if there are no other questions, thank you so very much, Dr. Jasmita.
Thank you, sir.
Let's move on to the next session in the next talk in this session. Here we have Colonel Uday, the young hematologist from Armed Forces. He is working in FMC Pune. Uday is alumni of PGI, and I think all of you know him. I call him, why Uday means award Uday, because the number of awards that he has won, even he doesn't remember the number of the awards that he's been getting, and he continues to get many more. So I think this special applause for all these awards to Uday. He has been a very favorite student of mine. And I actually feel happy that Uday and I see Harshit here, who's going to the next speaker. They are actually holding the flag of hematology in Armed Forces, and we're very proud of these youngsters, because the journey that we started in Armed Forces, they are continuing that in a great way. So today Uday is going to talk to us on a very, I would say, neglected area in MDS. MDS itself is a very difficult disease to manage. And in that, anemia, which we tend to overlook, and which is not actually optimally treated in these patients. So he's going to talk to us about managing anemia in MDS. Uday, please.
Thank you, sir. Thanks for those kind words. So just a second. You can just. First of all, I'd like to thank the organizing committee, and it's real honor to stand on this podium and talking in front of the teachers who taught me. Thanks, Verma sir. We are here because of you today. Thanks, Ajay Sharma sir. We are in Forge because of you. So thanks for that, because when I had to take hematology, I walked up to him and said, "Kisa kaun sa institute lena?" And then he actually brainwashed me. Thanks to Harshit sir and Ajay Sharma sir, I passed out from PGI. Otherwise, I would have gone to AIMS. So I would be talking about anemia and MDS. Now, before I start my talk today, This is one topic which actually tells us the relevance of a hematopathologist, because without them, we are not there. The clinical hematologist cannot do anything. MDS is a bridge between a benign and a malignant hematology, and most of the anemias or cytopenias are dumped into the basket of MDS until unless we have got a good hematopathologist to actually label whether the patient has MDS or not. So with that, I would move ahead. Now, please scan this QR code because I'm going to have this interactive. The organizers always keep me post-lunch sessions, and to make sure that you people are not sleeping, the attendance will be handed over to Reena madam after this. So the night coupons will only be active for those people who answer these questions, for the dinner coupons. So firstly, MDS, it's not a benign disorder. It's a clear-cut cancer. So plain simple. Now, the incidence of MDS, if we look at it, it is, in India, we don't know the figures. AIMS and PGI should come up with some articles to bring out the actual incidence of MDS. But in US, it's around 4 to 5. Now, this is a summary of how the MDS happens. So approximately these many cases, 29% are above 80. So it's a disease of geriatrics, and more than 92% of the patients are above the age of 60. The average age is around 70, and approximately 5 children are diagnosed per year in US. In India, it would be different. Now, the topic for the day. Why are we talking about anemia and MDS? So the purpose is, the anemia actually occurs in almost about 90% of the patients with MDS, resulting in significantly increased risk of mortality. Now, if you would see the thing here, the average survival, the median overall survival in patients who have less than 8 hemoglobin versus above 10, the leftmost panel, 2 versus 5.5 years. So that is a difference in the survival. And if you look onto the right side, the hazard ratio or the HR is almost 5.5 in males and 5.3 in females for those people who have low hemoglobin versus high hemoglobin. Now, it is both causative as well as the effective form of the MDS which lead to this. MDS leading to anemia means there is a lot of pathophysiology which has occurred, which is driving it towards to a bad prognosis. At the same time, anemia requiring more and more transfusions, iron overload, comorbidities associated with it can lead to further problems. So either ways, it leads to a poor prognosis. Now, if you look at it, the transfusion dependence is associated with the worst prognosis compared to transfusion independence. 56% decreased risk of death for those people who are transfusion independent. And if you look on the right hand side, the number of transfusions per month, you could see those who have received almost 4 units of PRBC every month, the mortality is almost equivalent to a lung cancer. So it's that bad is a situation if a patient is transfusion dependent. Now, the transfusion patients with MDS has greater incidence of comorbidities, different cardiac, diabetes, dyspnea, hepatic events, infectious complications, fungal infections, all of them statistically significantly higher. And CVD is a leading cause of death in patients with low risk MDS. So these are all the reasons why we are talking about it. So the first take home message is anemia in MDS and transfusion dependence. It basically portrays a poorer diagnosis. So that's the first take home message for practicing hematologists as well as for the MD students who are here. Now let's discuss the further part of it using a case vignette. I'll describe a 62-year-old man who came with complaints of fatigue, had anemia, and the anemia went on to so bad state that he started using the car parking which is meant for the people because he couldn't walk very far off from the office, and with a past history of hypertension and smoking. So the first question which would come up is, people have already started answering. What further information would you like in this patient? MDS, anemia. Is this sufficient enough to start the treatment, or would you like any other answers or any other points? You don't have to write PGI. We understand we are all from PGI here. That's why we are here. So, okay, cytogenetics. Some people want risk category. Okay, cytogenetics. Anything else that you would want? Anemia, MDS. For me to start treatment, what are the other informations that you would be seeking? Okay, NGS, fish. Fine, agreed. So, okay, let's take this further and describe each point of it. EPO, very good. Fine. So, I've given you additional information. So hemoglobin is 7.8 with a high MCV, reticulocyte count low, erythropoietin levels of 80 milli international units. And based on the new WHO classification, it's MDS-LB because of 2% blast. And the cytogenetics shows SF3B1. And the revised WHO diagnosis is MDS-SF3B1. So, with this information, tell me one thing, because the last 3 speakers have spoken about WHO versus ICC. So, what would you prefer in a patient with MDS? Which classification would you go ahead with? Fine. So you would like to go ahead with WHO classification, 5th edition. So we'll talk about it. Why do you want to go about it? I also agree with you. So now this is the latest WHO classification, the 5th edition, wherein these are the various categories. Now we define MDS with genetic abnormalities and morphologically defined. And we don't describe by the previous things. We classify them into low blast, hypoplastic, increased blast, and fibrosis. 4 categories. And this is the ICC classification. ICC classification somehow in MDS is akin to the old WHO classification. But there was a study which was done at US wherein they have seen that the agreement in ICC is extremely poor. Only 72% people agree. There are 27% pathologists, hematopathologists who don't agree with each other on the diagnosis when they use the ICC classification. So MDS, it's better to use the latest WHO classification, and it's also easier for the clinician to take decisions. And as far as the various risk scorings are concerned, nowadays, this is one area where you also have machine learning into it. And you have got machine learning algorithms for personalized scores for MDS. But it's preferable to use IPSS-R because we define the patients as low risk or high risk based on IPSS-R, cutoff of 3.5, and that helps us. Now, mutations is the next thing. Now, this is a major problem in the practice other than bigger institutes like Pgi and AIIMS. The reason being, people don't know what the anemia is because of. First evaluation that they do is to send a NGS panel. Nowadays, it's hardly 10,000-15,000 rupees. Rather than asking for a pathology report, they ask for a panel and you get an array of various mutations, and then they decide whether the patient is MDS or not based on NGS, which is wrong. So, but this is how the various risk factors are: the good risk factors in green, bad risk factors in red, but still the odds ratio, even for the good risk factors, can be bad as shown here. So, use a consistent classification system in an institute, preferably WHO and IPSS-R. Now, the next point is, once we have diagnosed that a patient has got anemia, how do we treat him further? So, the next question is, what is your first choice in a case of low risk MDS? Please mind it, in the scientific program it is written, sponsored by BMS. एक आध कोई तो luspatercept के लिए marks दे दो. Otherwise, रात को dinner नहीं मिलेगा. Your organizers will have to then मतलब ना pay from their salaries for the conference money. Thank God. Fine. So another point is, that was on a lighter note, but most of you agree that it is ESAs as a first choice. This is a classical algorithm which was published in the book in ASH 2019, which still remains good. For those people who actually have good counts, you can go ahead and treat them and just follow them. Do not give any treatment. For isolated cytopenia, and we are talking only about the anemia part of it. So, hemoglobin less than 10 and the patient is symptomatic. Please remember, symptomatic. There, we start with erythropoietic stimulating agents. Please remember, ESAs, the dose that we give for the ESAs has to be 500 micrograms of darbepoetin. A lesser doses really do not help. We earlier used to give 40, 100, then we went on to 200 micrograms, but it's around 500 micrograms which is supposed to be given. But the biggest fact that you all need to understand is the response rate with ESAs across world has been only between 15 to 40%. On the left-hand side, a decade earlier, a meta-analysis was published which shows that the overall response rate was 39.5. And on the right-hand side, there was a study which was a randomized control trial which shows the response at 24 weeks is around 15%, maximum to 35% by the end of 48 weeks. So the ESAs has its own limit, the response rate best up to 40%. Now, how do I decide whether I should go ESA or directly go with a newer agent? So this scoring system really helps, wherein erythropoietin is an integral part of this scoring system. And based on this scoring system, we divide the people into 3 categories, and that can tell us which one can have a better response and which will have a bad response. Now, for those people who belong to intermediate or poor response, the drug of choice happens to be luspatercept. But please remember, irrespective of who is sponsoring this session, the best responses are 38%, not beyond that. And as you keep going ahead, 33, 32, 19, 28%. The average duration, the median duration of response is also modest. It's around 30 months, 30 weeks. That's all is the transfusion independence that you have with luspatercept. That's why there is a quest to look for newer agents and to look how to treat them differently. So the next take-home message is first choice remains to be ESAs at higher doses followed by luspatercept. Now, the same patient we managed as we discussed with darbepoetin, and thereafter the patient had initial rise, again fell down, and we did NGS again. Now it shows ASXL2. The next option for those patients who are actually deletion Q positive or who are non-responders would be to give lenalidomide. This I'll slightly dwell upon because len is a beautiful drug. And there are multiple trials which have been done on len. And the best responses till date in MDS are patients with ring sideroblast or with 5q deletion or SF3B1, where you have 61% response and the median duration of response of transfusion independence up to 2.2 years. So this is one of the best responses which a MDS can ever get. Now the next question is, let's take a patient does not have ring sideroblast or does not have a 5q deletion. Can I still go ahead and give len? Now this question I asked Verma sir, whom we all call him as a nickname God, around 10 years back, and he said, "Beta, thoda bahut to de do." Sir ke do standard hua karte the, thoda steroid de do, thoda len de do. So he used to say, "Thoda len de do." Then we used to wonder why. But the same thing, actually, later in 2016, there was a randomized control trial which showed that if you give lenalidomide in patients who do not have 5q deletion or SF3B1, even they respond. Though the responses are modest, but better than erythropoietic stimulating agents or the current newly available drug luspatercept. And the duration is also not bad. It's 32 weeks. Whereas in luspatercept, we saw it is 30 weeks. Now we are talking about a group which does not have 5q deletion. So len is a beautiful drug which can be taken forward. Now the other newer agent, which is imetelistat. It is a telomerase inhibitor. So this actually can be taken for anti-aging purposes also. So there was a study which was done to show that it can have a benefit. So the next take-home message is len, best responses with RS and 5q deletion, also has moderate responses otherwise, and telomerase inhibitors can be given. Now going ahead with our patient, this was low risk that we were talking about. Now the patient shifted to high risk. So what would you do if a patient has got multilineage dysplasias? So the answer remains to be two things, either hypomethylating agents or ATGs. The next question is, most of us give hypomethylating agents. So what would be your choice? How many days would you go ahead and give hypomethylating agents in patients with MDS? We are not talking of AML, MDS. So everybody agrees for 7 days? Okay. So the next question is, what would be your choice of hypomethylating agent? Fine, people vote for EZA over distabin. Fine. So now, quickly coming on to it, for modifying the MLD, hypomethylating agents, 3 days is sufficient. And in fact, less is more. I'll show you why. Now, this was a study which was done, and the median duration of follow-up was 68 months. And you see here, by just giving 3 days of hypomethylating agent, overall response rate of 54%. With a transfusion independence rate of 32% and a median overall survival of 33 months. And the cytopenias less, infections less, and more suitable in resource-constrained setting like ours. So the next take-home message is 3 days of HMAs are sufficient in patients with MDS with MLD. And there is no difference between destabin and azacitidine for MLD. I'll come to the other part. Now, IST, that is immunosuppressive therapy with ATG, can be given for people who have hypoplastic MDS, and it has real good results with this particular thing. So the next thing is HMAs, less is more, 3-day therapy is sufficient. Now coming to the last part of my talk, the patient becomes high risk now. He has got 12% blast, so IB2, and he also develops newer mutations, -7, deletion 7, and TP53. So he obviously goes into the high risk. What would you do? Obviously, if a patient has got a complete match-related donor, go ahead with a transplant. But I will also give you some data against the transplant. and give hypomethylating agents. Now, here is the case where azacitidine has scored higher than destabine. So, there is a clear data to show that the overall response rate with aza is better than that of decitabine. But we never compare apples with oranges. These are two different subsets of patients, two different centers where they did the trial, but still the data goes in favor of azacitidine for high-risk patients. There are newer drugs like oral cedazuridine, which is a cytosine reductase inhibitor, and combination with oral destabine, where they found to be of some benefit. Now, quickly coming to the last part, that is transplant. Now, what you see here, in low-risk patients, the yellow line is non-transplant, whereas blue line is transplant. So, obviously, in low-risk patient, no transplant. Now, in high-risk patient, please understand these two, yellow and the blue lines. The yellow line cuts off the blue line after 48 months. That is the first 2 years to 3 years. The patients without transplant are better than transplant. And if your patient has survived well, for the first post-transplant period without infections, etc., he might have a survival benefit. But you also need to understand when they say that the transplant is better than no transplant, the no transplant group, almost 42% of them never received HMAs also. So it's always a game of playing around with your selection bias of the type of patients that you choose. So this is a horrible study to prove that transplant is better in high-risk patient. Actually speaking, a subset analysis of it showed that transplant really does not benefit high-risk MDS also. So the last conclusion, as are better than destabine in high-risk patients, oral destabine plus cedazuridine is a future, and transplant modest results. So please be careful. I'm a thorough transplanter, but still, a transplant in high-risk MDS is a question mark. So I conclude here. Thank you, sir. Thanks a lot.
So you realize that why I was saying that Uday does things in a different manner. So it is, he delivered this talk in a wonderful way. Thanks, Uday. There will be questions. One thing I want to highlight is because anemia actually is not because of the difficult diagnosis by the hematopathologist. It is by the delayed diagnosis by the clinician, because we neglect anemia. We don't think that anemia could be because of MDS. We don't investigate these patients and we don't get the marrow done in time, and then the diagnosis is delayed. So I think the clinician has to wake up to all these parameters given by Uday, that you should identify this anemia as not because of B12 deficiency or nutritional deficiencies. MDS should be ruled out. Yes.
It's a fantastic talk, Uday. Congratulations. What about a combination of EZA plus venetoclax? You didn't mention about that in high-risk MDS.
Sir, first of all, it's not an approved indication, FDA-approved indication for MDS. In AML, agreed, when the blast percentage has crossed 20%, and as far as the ICC is concerned, 30%, they still consider that. So, but the fact is, in patients who do not have about 20%, then venetoclax plus azacitidine might not be a good option. And second, when as such leads to so many cytopenias, so really I doubt if the investigators would like to work about using ven in patients with high-risk MDS. So, I'm open for thing. So.
So, Uday, excellent talk as always. The only thing is that you don't always need 500 micrograms of nabopoetin. In fact, there is a subset of patients who would respond to 200, and in those individuals, you don't really require 500. So my choice is start with 200, especially if your EPO levels are less than 200, and if there is no response, then escalate the dose.
So totally taken, once Verma sir has said, then there is no discussion after that. But the fact is, what I basically wanted to convey the message is, before saying that the erythropoietic stimulating agents are not working and shifting to a next line of therapy to go to the ceiling limit. So that was my message. So.
Yes, then there is a reason in India. That's true. We should start with the minimal dose. You're very right, Verma sir. And then before we write it off, one should use the maximum dose. Definitely, should give enough time before we switch on to the next line in therapy. Yes, Harshit?
So a wonderful talk, Uday. I just want to know, as far as the current literature and approval status of luspatercept goes, it is for SF3B1 mutation only as of now, though data for others and in general MDS is coming up and showing a good response. But would that message be prudent to give to the audience that right away you can consider luspatercept for all across right away at this moment? That's my question.
So the NCCN guidelines version 20231 says that luspatercept, as you rightly brought out, ring sideroblasts higher percentage of RS and presence of SF3B1. But it also mentions AAMT and then it puts an asterisk mark and gives it in the non-patients of those who are not responding to ESAs in the low risk category. It still mentions it as one of the options. So can be used maybe.
Very nice. So that's just one question. Sometimes when you do a marrow of MDS, you find marked erythroblastopenia, like PRCA-like picture. So your algorithm stands at that time also, or do you use other things?
Ma'am, with erythroblastopenia, definitely like all clinicians would like to rule out the various causes of the viral induced and the acquired PRCAs for that particular part before jumping into the label of diagnosis or treatment as per MDS. Now also ma'am, that apart, one more area which most of the MD students should remember, a partially treated B12 deficiency, a copper deficiency can also mimic like a MDS most of the time, and wherein it would be fruitful to actually do a marrow post replacing those people with vitamin deficiencies or looking for a copper deficiency. So these are other places where it can mimic MDS. So.
Yes, by definition, erythroblastopenia should not be a feature of MDS. We should look out for the other causes. I thought Dr. Smita is walking to the mic to, no. Okay, good. So with that, I think we move on to the next talk.
Thank you, sir.
Madam, will you?
It gives me great pleasure to invite another star alumnus, Dr. Harshit Khurana. He is a clinical hematologist and BMT physician, professor and head Department of Geriatrics and Medicine from Armed Forces Medical College, Pune. His areas of interest are aplastic anemia, polycythemia, and myeloma. Dr. Harshit, please.
Thank you, Chairpersons. It's a proud privilege to be standing here on this podium today in front of the teachers sitting as chair and in the audience. So I shall begin with my talk. So JAK2 inhibition in MPN, when to and when not to. So standard classification, as Dr. Jasmita has told, MPN-U now MPN not otherwise classified, the pH positive MPNs and the pH negative classical MPNs and the non-classical pH negative MPNs. So the talk will focus more on the MF, myelofibrosis, the polycythemia vera and the essential thrombocythemia, which are driven by JAK2 mutations. So dysregulated JAK signaling is the hallmark of most of these patients harboring these malignancies. So coming to the phenotype, driver mutations activating the JAK-STAT pathway in the MPNs is as shown in the figure. So commonly mutated genes in all three. 100% of JAK2 mutations are there in exon 14, 97%, or exon 12, rest of the up to 3% patients of polycythemia vera. The ET comprises 60% of JAK2 mutation and 20 to 25% of KLR mutation and 3% of MPL mutations. And the myelofibrosis, the primary one, has 65% JAK2, 20 to 25 KLR and 7% MPL mutations. And approximately 8 to 10% of myelofibrosis and 10 to 15% of ET may be triple negative MPNs. So coming to the protagonist, whether it's a hero or a villain, a hero for the doctors, the villain for the patients, it's a 7 genus homology domain structure which has an N-terminal and a C-terminal. The V617F mutation occurs in the pseudokinase intracellular domain of the JAK2 mutation, which has a basal inhibitory effect on the kinase in the intracellular pathway, and the mutation takes away that, it breaks that basal inhibitory effect of the pseudokinase on the kinase domain. So the dysregulated JAK signaling leads to the abnormal levels of cytokines in blood, leading to inflammatory response, and bone marrow fibrosis, leading to impaired bone marrow function. So the intracellular pathways that are involved are essentially the JAK-STAT signaling pathways and the MAP kinase or the PI3-AKT pathways. As shown in the slide, the pointer doesn't seem to show much here. Yeah. So the MAP kinase activation pathway leads to cell proliferation and the cell growth and survival, and that's the standard JAK-STAT pathway, leading to the cellular proliferation and transcription. So this was a paper back in 2012 by Teffrey et al. And this mentioned that the benefits of JAK2 inhibition, the more the target specificity, the more the side effects. And the lesser the target specificity, the more the side effects. And the side effects based on the JAK1 or the JAK2 inhibition or a pure JAK2 V617F mutation are as shown. So essentially, it causes anemia and thrombocytopenia, the drugs, the JAK2 inhibition, rebound cytokine, rebound withdrawal on sudden stopping of the drug. And in addition, the off-target activity of the FLT3, RET and JNK pathway may lead to peripheral neuropathy or gastrointestinal system symptoms or as a side effect. So essentially, both JAK1 and JAK2, they drive the aberrant cytokine production and immune dysregulation, leads to clonal myeloproliferation, further leading to ineffective hematopoiesis, extramedullary hematopoiesis, alteration of microenvironment, the leukocytosis and thrombocytosis, and further leading to clinical manifestations of cytopenia, splenomegaly, bone marrow fibrosis, and blastic transformation. So this was the first kid on the block, the ruxolitinib, a non-specific JAK1 and JAK2 inhibitor, which potentially had the inhibitory effect of cytokine and growth factor receptors that use both the JAK1 and JAK2. It suppressed the malignant cells. It downregulated the cytokines that contribute to the hypermetabolic state. So coming to the earliest trials which showed robust responses because with the JAK2 was and improved the overall survival as well as basically symptomatic improvement and overall survival improvement in the patients of myelofibrosis was the COMFORT-1 and COMFORT-2 trials. And subsequently, with the real-world data showing the utility in intermediate and high-grade more so, and impacted the overall survival of the patients with the post-approval ruxolitinib exposed to a significant effect. So this became a benchmark or an important drug in the management of myelofibrosis. So as of current status, the drug was approved for intermediate 2 and high risk and for the management of myelofibrosis and based on various risk stratifications. In addition, it is also used as a bridge to transplant sometimes to bring down the cytokine storm in the patients. And now it is recently upcoming for low risk patients who have significant symptoms also. So the clinical benefit of a JAK2 inhibitor therapy in myelofibrosis was significant as far as the total symptom score or the splenomegaly was concerned. These initial molecules which were inhibiting the JAK2 in active conformation and were called type 1 inhibitors. So ruxolitinib became the standard of care for patients with intermediate or high risk myelofibrosis with symptomatic splenomegaly or constitutional symptoms. And the COMFORT trials established that splenomegaly and symptom burden could be reduced and cytosis and inflammatory cytokines could be reduced, and which was a significant improvement in the management of myelofibrosis. So approved JAK inhibitors till a few weeks ago were ruxolitinib, fedratinib and pacritinib. These are all type 1 inhibitors. So coming to while the clinical benefits of ruxolitinib are undeniable, the drug does have some limitations. The non-driver mutations associated with JAK2 in patients of myelofibrosis or additional mutations, they substantially lower the odds of spleen response and lead to inferior overall survival. There is a clinical resistance due to persistence phenomena whereby the JAK2 gets trans-activated by heterodimerization with another member of the JAK family despite the presence of an inhibitor. And patients who discontinue the drug have further dismal outcome with a median overall survival of 13 to 14 months and patient going into clonal evolution. And anemia is the most frequent reason for discontinuation. Thrombocytopenia with platelets of less than 50,000, the drug is contraindicated and it was a major hallmark of myelodepletive phenotype of the myelofibrosis. Coming to the reason for the persistence phenomena was because of the central role of this pathway, the MAP kinase and further the ERK activation pathway. So JAK heterodimerization led to reactivation of JAK2 signaling, and there was upregulation of PDGFR signaling as a JAK2 independent mechanism which leads to the persistence phenomena despite a JAK2 inhibitor. So defining failure of ruxolitinib in clinical practice, the primary resistance is when there is no change in spleen length by palpation, no reduction in spleen-related symptoms, and less than 50% reduction in the MPN symptom assessment form score, or unacceptable to the patient. Then there can be a secondary resistance with loss of initial spleen response and return to baseline, loss of initial symptom response and return to baseline, or an intolerance because of any unacceptable treatment emergent toxicity with a platelet count of less than 35,000 and a doubling of RBC transfusion rates, and or progression with increase in blasts or increase in spleen length from baseline. So initially these 3 drugs were approved. The ruxolitinib was the first kid on the block. The problems were anemia, thrombocytopenia, and withdrawal syndrome, along with opportunistic infections. Then came the fedratinib, which started working in 2013-14, but thereafter there was a stoppage in the trial because of the issues of Wernicke's encephalopathy, and monitoring of thiamine levels was suggested. And this pacritinib was approved a couple of years ago and for patients with thrombocytopenia. So this was the current approval status till about a few weeks ago. However, pacritinib does have additional side effects of gastrointestinal symptoms and cardiac side effects. So coming to the new kid on the block, this is an emerging treatment for myelofibrosis patients with anemia, leads to transfusion independence and increases the hemoglobin by inhibiting the IL-6 based pathway and the ACVR receptor. Further, to show how it does it, so there is essentially increased hepcidin in patients of myelofibrosis, leading to profound functional iron deficiency anemia. Momelotinib mediates the plasma iron elevation, leading to stimulation of erythropoiesis and RBC production. So by decreasing hepcidin transcription from the liver, it restores iron homeostasis and increases hemoglobin, leading to an array of anemia benefits. So the new approaches to tackle cytopenic myelofibrosis as per the ASH guidelines was, till a few weeks ago, momelotinib was an investigational agent, but just about a couple of weeks ago, it has been approved for use with myelofibrosis with anemia. And only significant risk factor is the peripheral neuropathy. So coming to the modification now that should be there in the suggested myelofibrosis management protocol is, in cases of constitutional symptoms with platelets more than 100,000, the first drug to be preferred is ruxolitinib, maybe followed by fedratinib. If in lower patients, a lower platelet count, a low dose ruxolitinib, a fedratinib or a pacritinib can be considered, and with platelets less than 50,000, pacritinib is the only drug suggested. However, with anemia, till now, these were the only supportive care managements which were being suggested. And now, momelotinib can be added to this protocol for patients of myelofibrosis with anemia. So coming to, we've discussed myelofibrosis, coming to the other MPNs, the polycythemia vera and essential thrombocythemia, again driven by, mostly by the JAK2 mutation, which is the top subject of the talk today. So essentially, again, as shown, 96 to 100% patients have, 96% patients have JAK2 V617F, about 3% have JAK2, and 1% may have some other subtype or other JAK2 mutations. So second line therapy in polycythemia vera, whether hydroxyurea or ruxolitinib. The first line is phlebotomy. So ruxolitinib is now FDA approved to treat patients with PV who are resistant or intolerant to hydroxyurea. So coming to the criteria, the ELN criteria to describe how the hydroxyurea resistance or intolerance is considered. So based on the need for phlebotomy, the platelet count, whether very high or WBC count high, no reduction of splenomegaly, no reduction in spleen symptoms, the cytopenias, and or the additional side effects of GI toxicity, fevers, leg ulcers, or cancers of the skin or mucocutaneous toxicity, and at any dose. However, in real life clinical practice, we do switch over earlier, even though these criteria may not be met. So the response trial showed that ruxolitinib, the median duration of primary response was not reached in PV patients where the ruxolitinib was indicated for symptom improvement. Coming to the role of JAK inhibitors in PV now, in current scenario, it is effective in hydroxyurea refractory or intolerant PV. The response 2 and MAGIC PV trials have shown a significant improvement of symptoms and splenomegaly. And patients of post-PV myelofibrosis with drug refractory pruritus or symptomatically enlarged spleen can be considered. And management of pruritus, a low dose ruxolitinib may show some effect. And high-risk patients, prior to starting ruxolitinib, a PEG interferon role is suggested in the current scenario. So with the current therapeutic approach, JAK2 inhibitors comes after the pegylated interferon as per the recent research paper. However, based on the symptomatology score and tolerance to interferon, one can choose the thing. So coming to essential thrombocythemia, the treatment protocols are as shown in by the ELN or the ESMO guidelines. No role of ruxolitinib suggested. With the MAGIC ET trial, it did not show any superiority with the current second-line treatment. The ruxolitinib did not show any significant benefit. So clinical benefit of JAK inhibitor therapy in PV and ET, based on the response study, ruxolitinib has been approved for patients with PV resistant or intolerant to hydroxyurea and effectively reduces the hematocrit, splenomegaly, and symptom burden. Ruxolitinib therapy also resulted in a lower frequency of thromboembolic events relating to reduced hematocrit and inflammation. And in ET, ruxolitinib has not shown any additional clinical values so far. So coming to summarize the management of MPNs, with the 2005, the JAK2 mutation was discovered. In 2006, MPL mutation discovered. Ruxolitinib approved for myelofibrosis in 2011. 2013, CALR mutation discovered. Fedratinib approved in 2019. And in 2022, the pacritinib was approved. And now in 2023, just a couple of weeks ago, momelotinib is approved for MF with anemia. So limitations of JAK inhibitor therapy in MPN, it has a limited disease modifying potential. Anemia, thrombocytopenia, and immunosuppression are the main issues. JAK1 inhibitory activity may lead to opportunistic infection, especially tuberculosis in our setting and other viral infections. And secondary cancers, though not proven, however, increased association has been seen. And there is a loss of response to JAK inhibitor therapy seen in approximately 50% of patients, and resistance. So potential future avenues, the JAK2, type 2 JAK inhibition in inactive conformation has promising effects on mutant allele burden. Different concept of JAK2 pseudokinase inhibitors, as I showed on the molecular pathway of the JAK2 molecule, the pseudokinase domain inhibition, and combining the JAK2 inhibition with, this is the last slide actually. So combining the JAK2 inhibition with targeting of additional factors with different additional factors. These are there are a lot of trials going on, and some of these drugs are showing good effects. So to conclude, discovery of JAK2 mutation, insight into molecular pathogenesis of MPN has impressively increased and has provided a rational basis for development of targeted therapy approaches. And novel JAK2 inhibitors and combination therapies are expected to become part of clinical practice. And JAK2 remains central to disease understanding and a target of MPN. So thanks to the audience for a patient and listening. And secondly, I would like to thank the institutions of my learning. And last but not the least, many thanks goes to the PGI Hematology family for having me here to present this talk. Thank you.
Before we open the subject for discussion, I would like to welcome two matriarchs of PGI who have taught generations of all of us who have now gone to various places all over the world, Dr. Deepika Mohanty and Dr. Shobha Sehgal. Thank you very much for coming and being here.
Any questions?
Who would you transplant?
Sir?
Who would you transplant?
Who would I transplant? So high-risk MF with the high-risk mutation profile of the non-driver mutations, and based on the risk stratification, the age appropriate, the clinical profile and performance status okay. So, and the high-risk subgroup of patients who are transplant eligible should be transplanted. Any further questions?
So if there are no more questions, thanks.
There are no more questions. Thank you very much.
Thank you,
sir. It was a very illuminating talk. Next we have Dr. Brigadier Ajay Sharma, who moves from his position as a chairperson to a speaker. Dr. Sharma is a senior consultant, was a senior consultant in Department of Clinical Hematology at Gangaram Hospital. Previously, he has been at CMC Vellore and Armed Forces Medical College. And he has recently moved to Paras Hospital in Chandigarh as a consultant. Dr. Sharma has numerous areas of interest, her bone marrow transplant, and he has numerous awards and achievements. Dr. Sharma.
Thank you, sir. And once again, thanking the organizer for giving me this opportunity. Moving on to the next topic from the real bastic discussion that we had, now coming to this talk on unmet needs and treatment landscape in CML. It is a sponsored talk, though I want to clarify that the thoughts here are mine, and I have nothing to disclose. The title of the topic is Unmet Needs and Landscape. So I was looking at the exact meaning of unmet needs as it applies to CML. So we have unmet expectations, and we are looking for the making newer therapies available to achieve cure. Will it be different for patient and the doctor? Are their expectations different? This was looked into in a study recently reported in EHA, where patients, by and large, they were satisfied with the kind of therapy that they were getting, and but there were many areas where actually they found that they were not very happy, feeling fatigued, emotionally fatigued, and then cannot carrying out their work and workouts, and stressed about treatment failure. So these issues remain central to the management of CML, even though they otherwise looked quite satisfied as well as the clinicians were concerned. The physicians, on their part, they find that, they generally believe that they are central to the management of CML, and they thought that they always involve the patient in the discussion, but actually, in reality, 74% of the physicians found that they were the sole decision makers. So while the patient wanted that the decision should be taken up with the discussion that they can have with the doctor, but in most of the instances, the decision was mainly taken by the doctor, and the involvement of the patient was not very much. This applies very much to our country, where the discussion is usually unilateral. So we need to change this outlook in our management. Now, the top 5 treatment goals, again, can be different for patient as well as the doctor. The patient would see in terms of the side effects, to have the treatment stop because of this disease progression, improving quality of life, the disease control, and ultimately the cure. While a physician would look at achieving an MMR or more beyond that, and improving quality of life, achieving deep molecular responses, minimizing side effects would come as lower priority, and maybe achieving TFR. So these can be the difference in the perspective of these patients. Does CML have different impact on Indian patients? We were just talking about the Indian classification for MPNs. Yes, there are different impacts. While the classification may not be much different, but because the patients are affected at much younger age, the financial dynamics, social support, insurance system, they're all very much different in this country. So the impact of the disease, the management is much, much different in our country. It is a disease of young adults in India as compared to the Western population, where the diagnosis is usually beyond 60, and incidence also is much more in this country. In West, the CML is steadily, the prevalence of CML is rising because of the prolongation of the lifespan, and by the advancement in the treatment, the life expectancy for the patients is as good as for the general population. In our country, it is seen in much more younger age group. Incidence, we don't know how much actually it's really going to be. This is data from AIMS Delhi, was presented some time back in a small group of population, and this shows that how less informed we are about this disease. Interestingly, the survival has prolonged in our country also because of the availability of the good TKIs, and the survival rates may be as good as for the normal population of the country. This study found that the median age was 10 years lesser in Indians, and the percentage of asymptomatic patients was drastically low. Most of them were much more symptomatic, as we always see as compared to their Western counterparts. Splenomegaly, the constitutional symptoms, and high-risk score, they were all much more in our Indian population. So keeping all that in mind, do we need to have more aggressive CML therapy today? If we see that the patients who are moving from first line to second line to third line of the treatment, though the number decreases, but at the same time, the availability of the drug decreases, and also the disease becomes kind of more aggressive, the failure rates become much more. So we need to attack the disease in the very beginning. We cannot afford to let the disease progress. So the message would be that we should have the novel treatment options which have more effective at early stage rather than treating these patients at later stages when the number of mutations is much more, the new mutations keep appearing, and these mutations make the treatment much more difficult. Similarly, the patients in later lines of treatment have reduced overall survival. As you can see here, the 5-year survival moves on down to 82% to 77% with the move from the second line therapy to the third line therapy. So these facts should be kept in mind, and keeping that in mind, we should give our best foot forward in the first line of treatment itself, and that should be effective enough to prevent the disease progression. Then we have the number of drugs which we use as second-line drugs and third-line therapies. The off-target effects of these kinase inhibitors, they affect the drug safety, and the side effects are much more, and that affects the compliance because of the intolerance to TKIs, poor compliance, and drug failure. As you can see here, the discontinuation number for imatinib is just 4%, while for the other drugs, other second and third line drugs is much higher. So it is easy to continue the first line drug, whether it is first generation TKI or second generation TKI, as compared to the second and third line drug. The real world data has shown that more than 1 in 5 patients discontinue TKIs due to intolerance, with similar rates observed with imatinib and second generation TKIs. Then coming to the treatment goals. When the patients start the treatment goals are much different as compared to the treatment goals in the second and third line therapies. In the initial stage, the improved survival, the quality of life becomes very important, and patients with newly diagnosed disease wish to strive for early molecular responses and deep molecular responses, and trying to reach TFR as the goal, which may be of very importance to the younger patients that this country gets. As the disease progressive, the goals tend to change much. Practically, we try to settle at the cytogenetic responses and try to achieve the deep molecular responses. But in resource-crunched countries like ours, where the monitoring may be difficult, second and third line drug may be difficult to be afforded, the survival improvement may remain a practical option. Now, coming to the mutations, the 315I mutation, which is the main culprit for the poor outcome in CML, the new therapies are needed for the patients with this mutation, and as we know that this mutation is much commoner to the patient who have been treated with imatinib and the other TKIs. The patient with these mutations have poor outcome, and as we can see here, the overall survival at 5 years is much lower in patient who has got mutation as compared to those patients who do not have these mutations, and the risk of death is much higher in those patients with mutations as compared to the patients without mutations. We'll just study very briefly into the essence of PACE studies and then how it was applied in the OPTIC study. The PACE study told us about the efficacy of the ponatinib. It's been very effective. You can see here it has got a sufficient efficacy, but at what cost? The cost of the side effects. At the dose, at the optimal therapeutic dose, the arterial obstruction event, AOEs, were pretty high, and actually that led to the restriction of the drug as a therapeutic agent significantly. Till the time the optical trial was done, wherein we actually learned that by the reduction of the dosage, appropriate dosage, if we can reduce from 45 to 15 or 30 to 15, then once the patient has achieved the MR2 level, that is less than 1%, and the number of these responder actually was 51% if we came down to 45 to 15 and so on. So thus we can have the side effects reduced much effectively without having the efficacy affected much severely. So when we compare asciminib and ponatinib, we find asciminib appears to be better tolerated, but the ponatinib may be having much severe side effect profile. Mutations, if we study, we find that both drugs have specific roles in the TKI intolerance and KD mutations. Both have optimal efficacy against mutated ABL with appropriate dosage. There may be case for combining TKIs with the BCR ABL inhibitors, as we'll see. Does it mean that we need to now move on from these TKIs to further? There are novel TKIs which are being studied for the efficacy. We have vodobatinib or olverembatinib with the tongue-twister names, and also we have the fibroblast growth factor inhibitor Pgi-Hem-Onc, which is being now approved for the hematological malignancies including CML. These are found to be equally effective in resistant cases. The Pgi-Hem-Onc actually has been shown to have a very favorable responses used in a refractory situation. While looking at the landscape, we have the lot of immunological interest coming into the field, and applying these principles, we have certain drugs which are being now in the pipeline. We have the checkpoint inhibitors, because there is an increased expression of CTLA, cytotoxic lymphocyte antigen 4 in the T cells in CML, and the current trial is currently evaluating the efficacy of ipilimumab, which is an anti-CTLA4 drug in combination with nivolumab in the hematological malignancies including CML. Then we have mesenchymal stromal cell CAR T cells are finding their way into CML also, where we are using IL-1 RAP CAR T therapy and CD19 CAR T therapy just in very early the lab studies stage. And then there is a very encouraging use of interferon alpha in combination with TKI, because some of us in this room have got an experience of using interferon, but at that time interferon was used alone with some results, but if we combine it with a TKI, then the results can be much encouraging. So a key to successful outcome is the accurate diagnosis. Even though we have got the timelines for the second line therapies, but practically the real world experience is that the sensitive monitoring is very important. It is very uncommonly, it is not very often that we use it, and it is only very, the sensitivity level for detection of molecular response are very low, and the diagnosis is actually, the monitoring is suboptimal in these situations also. Now, what is looked at the economic burden in the patients in the later lines of therapy? See how there is exponential rise in the cost of treatment from the first line to second line to third line. This is the slide which I have taken from Novartis, and they have come out with this concept that the cost of the treatment becomes so costly as we move on from the first line to second line to third line. So it is not cost effective to not treat initial lines optimally. It is better to monitor these cases, diagnose in time, monitor them well, and use optimal therapeutic dosage of the first line drugs, and then to land up with these resistance. So to conclude, we have the CML wherein the treatment failure is pretty common, and currently we have the TKIs available, and the treatment failure risk increases with movement of each of the line in the line of treatment. The current third line TKIs have all get off-target activities that can lead to long-term safety issues, and patient gets a lot of side effects. The sequential TKI therapy is associated with increased resistance, and patients with 315I mutations have poorer outcome than patients who do not have these mutations. And over time, the treatment goals have evolved from improvement of survival to prevention of disease progression, improved quality of life, and treatment-free remission. The regular, sensitive, and robust molecular monitoring is most important for evaluating and quantitating the treatment response. And as patients may remain on TKI therapy for a long time, reducing the adverse effects, improving the quality of life have become the important treatment goals, and there is a need for strict and accurate monitoring of these patients. With that, I'll conclude about this newer aspects in the CML, which will remain open for all the times to come, because the disease is perhaps not going to go away, and maybe the transplant combined with TKIs will find a new way forward. Thank you very much.
Thank you very much. Thank you very much, Dr. Sharma. The paper is open for discussion now. I was particularly impressed that you emphasized the issues related to the cost-constrained society. We face that every day in Bharat, and we need to be aware of that.
Yes, the problem in our country is that the common man who is not a government employee, who is not, who doesn't have an insurance program, let us say the farmers, the unemployed people, the self-entrepreneurs, they do not have any support system. And for them, even though the first-line drug is provided free of cost in most of the institutions, especially the government institutions, the second-line therapy is not available free of cost to these patients. And by the time they land up into second-line therapy, most of them, they give up the therapies, and then they'll end up with the disease progression. So we need to evolve a system where actually perhaps that's a little complicated issue, how we can ensure that as much as possible, the oral therapy to these patients, if the generic drugs are available more and more, may be made available to the common man of the country. That is the area which is actually not being addressed.
Thank you very much. If there are no other questions, thank you very much, Dr. Sharma, and we announce this session closed. Over.
Thank you.
So indeed an enriching discussion. So with this, we come to an end of the session. I would like to thank all the presenters and chairpersons for giving their valuable time. So further we proceed for the Professor B.K. Eckert Memorial Oration, and I would like to call Dr. Radhika for the same.
A very important session. Some heavyweights are not physically but otherwise are in attendance, so I'm looking forward to the presence. I'm not looking at someone in particular, Dr. Adotra.
I request Dr. Anupam to welcome our Honorable Director, Professor Vivek Lal, with flowers. I request Dr. Meghal to welcome our Dean Academics, Professor Naresh Panda, and present him with flowers, please. I now request Dr. Pavan to present a floral welcome to the orator, Professor K. Krishnan. May I now request Dr. Adya to please welcome Professor B.N. Datta sir, former chairperson Pathology Department, who has been our guiding light for many years now. I now request our Honorable Director, Professor Vivek Lal, to give his welcome address and introduce the oration, please.
So, all the leading gurus, the kings, the queens, the emperors and empresses of pathology, I wish you all a very good afternoon. I stand here with pride in my heart, I'm telling you. And there couldn't be a prouder moment for me to be given the privilege of introducing a giant, a founder giant of this great, colossal lighthouse, which is PGI. I was asked to introduce the oration. What is the purpose of the oration? And you must have seen that I put this in my pocket, which I always do. You see, he was one of the founding fathers of the professor, as a founding professor of the Department of Pathology, Professor Aikut, a legend. I was doing my MBBS in Amritsar Medical College when we would hear his name once a while. And we also heard about this famous Department of Pathology, which is world-renowned for its CPCs. But that's just one small part of the story. Professor Aikut, with Professor Tulsi Das, Professor N.N. Vig, Professor Santokh Singh Adand, Professor P.N. Chotani, Professor Berry, Professor Bala Subramanian, Professor P.K. Devi, and so many others actually made PGI into a lighthouse, which it still is. Those of us who joined after he left would probably do well to remember that the richest legacy which he left behind, besides a powerful department, was the powerful tradition of CPCs, which are unique to this part of the world. I make a statement here, and I think that would be an absolute 24-carat tribute to his vision. When I met Professor Vinay Kumar, editor-in-chief of Robbins, he had come to meet me, and he said, Vivek, there are more CPCs in PGI in 1 year than the entire world put together. And I said, I'm not surprised. This department is unique, and the uniqueness of this department stems from a very rich legacy. That legacy continues. The power of commitment, the power of missionary zeal, which our forefathers, including Professor Eichert, gave us, still is live and kicking in this department. He has, if you see his list of medals and awards, there's nothing which he didn't get. And I'm not surprised that he got everything. He's a B.C. Roy awardee, he gave the Fulton Laureation, he did so many things which would be expected out of a man, a colossus of his stature. He was a giant. The legacy of a person, if you ask me, is known by how far it outlives the giant. And I make an announcement here, which I'm sure none of you knows, only I know and Biman Saikia know, that now these CPCs, for which PGI is famous for, are going to be broadcast by the Department of Telemedicine to Southeast Asia after next week. But I am not going to end there. I'm not going to end there. We've decided to do it to Singapore, Nepal, Vietnam, Malaysia, Indonesia, and I think in the week or next 10 days it should be live and kicking and running. But I'm not going to rest there. I want our CPCs to reach Harvard and Johns Hopkins. They should know what PGI stands for, what Professor Eichert and the founding fathers of PGI stood for. I was asked to introduce the oration. More than the oration, I thought it's the spirit behind the oration that should take precedence over everything. And it is in this noble spirit that I bow my head in front of giants like him, who made PGI such a magnet that when I qualified for the first time in PGI in Jan 1987, and I didn't get the subject of my choice, I went back. I had got All India Institute. I said, I'm coming here. And I came back in July 1987. I came back, lived on, survived PGI, I'm doing well. So that is the biggest tribute to such giants. We have orations, we have memories, we pay tributes, but nothing comes near acknowledging a giant if we pay tribute to his legacy. When I am in Delhi, as a director, they ask me, tell me what is your infrastructure like, what is your suprastructure like. I say, my infrastructure is the commitment of my colleagues, my infrastructure is the commitment of my healthcare professionals. And if you talk of buildings, they are suprastructure. I had once gone to Harvard. I was invited by Professor Louis Kaplan, so he took me around. And I was surprised to see, it was around lunchtime, I saw the lawns were full. I said, Professor Kaplan, who are these who are basking in the sunshine. They said they are healthcare professionals, they are residents, they are doctors. So I said, how do they get time to sit here? We don't see the sunrise, we don't see the sunset in India. So he made a statement. He said, my drawing room is full of Ganeshas because I know every Indian doctor represents a Ganesha. He had come to PGI, he had seen PGI, he had seen how we function, and he mentioned very casually that the power of Indian medicine, he's a very well-read man, he has been the neurologist to 3 Indian prime ministers. The power of Indian medicine lies in the commitment, in the courage, and the missionary zeal with which we all work. If we understand this, then the spirit of this oration will soar higher than what it was before the oration, and the Institute's flag will continue to soar higher and higher. With that, I welcome you, sir. You are an ex-PGite, but PGI is a lot different. You left it when it was a village. Today it is a live and buzzing city, I must say that. You must have seen the traffic on the roads. No rules. That's all. And you're lucky if you didn't bump into someone or someone didn't bump into you. Have a safe stay here, sir. Thank you so much for coming. I once again welcome you all on behalf of this institute. Each and every person in this department which has come from PGI deserves kudos for taking this department to easily amongst the best in the world. Thank you. Jai Hind.
Thank you for that wonderful and fitting introduction, sir. Your leadership inspires us all. May I now request Professor Radhika Srinivasan, Chairperson, Department of Pathology, to introduce the orator.
Thank you very much, Navjeet. Honorable Director of PGI, Professor Vivek Lal, Dean Dr. Naresh Panda, Professor Krishnan, the orator, my revered teachers, Professor Datta, Professor Segal, Dr. Mohanty, Dr. Garewal, Dr. Mrs. Banerjee, Dr. Mrs. Datta, and so many others, Dr. Bakul Dalal, again our alumnus, Dr. Ghosh. I mean, all of you have come, and today it's such an auspicious day for the department itself. This oration, there are also delegates of this conference, the residents, and the faculty of Pgi-Hem-Onc. Thank you all for coming today. And it's my pleasant duty today to introduce the orator. Can I have the next? Yes. So this just had a few slides in our archives, and that is, of course, this is Professor Ikat there, and this is at the inauguration of Research Block A, and which is why you have the Zakir Hall there. The next slide. Yeah, and that is, of course, at the visit of Sri D.P. Dhar, and this is Professor Chutani. I mean, I'm just showing these pictures for the youngsters, and this is, of course, the legendary Professor Ikat. Next slide. Yeah, so today's orator is Professor Koyemangalat Krishnan, who is currently the Chief of Hematology Oncology at the James H. Quillen College of Medicine, East Tennessee State University, Johnson City, USA, who began his journey in Kilpauk Medical College in 1979 and did his MD Pathology in 1981 to 84. So he was our junior resident then. And sorry, the next slide. Yeah, and I got this. I think that this is Dr. Krishnan. Am I right, sir? I think that is Dr. Krishnan, the young Dr. Krishnan in our department. So from PGI-MER, the journey of Professor Krishnan took him to UK, where he obtained a diploma in hematology in 1987 from the very famous Royal Postgraduate Medical School, Hammersmith Hospitals, London, working with giants there in hematology, obtained his MRCP, and then moved on to another great hematology, University of Michigan Medical School at Ann Arbor. So he's worked in the top institutions across the world. And then he went on to do his residency from the East Tennessee State University and continued there as a faculty. He is a physician, a medical oncologist, and a hematologist, all rolled into one. He's held several appointments, from 2004 to 6, he was also the assistant professor at the MD Anderson Cancer Center, Houston, Texas, there. And from 2006 onwards, he is being the professor of medicine, Dishner Chair of Excellence in Medicine at the East Tennessee State University. Member of several committees, his CV runs into several pages, so it's very difficult for me to give you the nutshell of it. I can only show you the tip of the iceberg, I would say, of what Professor Krishnan actually is. Member of Cancer Research Committee, Thesis Advisory, Oncology Committees, etc., etc. Member of working groups like the Colorectal Cancer Working Group, Survivorship Programs, and so on. Director of the Fellowship Programs, Chair of the Clinical Trials Committee, reviewer and editorial board members of several prestigious journals, and I think he's the academic editor of PLOS One. Further on, his main field areas of research are cancer prevention, cancer survivorship, colorectal cancer, and prostate cancer. He's had several grants, including NIH grants. One of his NIH grants is on instructional modules to improve cancer communication. So he's an excellent teacher there. And he's also had grants for research in prostate cancer and also some rural cancer demonstration project and so on and so forth. And he is involved in numerous clinical trials. I really can't list all of them. He's been a teacher, a mentor, a researcher to several students, numerous international publications, 12 book chapters, and he's still actively publishing. He's in the Cambridge Who and Who and in the America's Top Physicians list for several years. And the crowning glory, I think, will come tomorrow. He is the chief editor of the PGI textbook of hematology. And with these few words, may I now request the stage is all yours, Dr. Krishnan, for the 12th Professor B.K. Ikat Memorial Oration. Thank you.
My sincere thank you to the Director of PGI, Professor Vivek Lal, Academic Dean of PGI, Professor Naresh Panda, Chair of Pathology, Professor Radhika Srinivasan, Heads of Departments of Hematology and Clinical Hematology, Professor Reena Das and Professor Pankaj Malhotra, distinguished faculty members of the Department of Pathology and Hematology for bestowing upon me the honor of this oration in the name of Professor B.K. Ikat. I did not have the opportunity to work under or be taught by Professor Ikat, but I have heard several anecdotes about him through the years from those who have. Stories abound about his punctuality, his devotion to teaching his residents, his guardianship and mentorship of his PhD students, his astounding knowledge of pathology, his visionary approach to the creation of the Department of Pathology, his love for CPCs and experimental pathology. Previous students of Professor Ikat remember his good afternoon doctor quip to the resident who came later than 8 o'clock in the morning, his eagerness to work on Sundays, his late night work schedules, his magician-like flair as he exposed the diagnosis at CPCs. He was described by a retired senior faculty member as a teacher with a rough exterior but kind heart. I also would like to pay my respects to my previous teachers, who some of them I'm seeing after several years. And they include the revered Professor B.N. Datta, Professor Deepika Mohanty, Professor Shobha Sehgal, Professor Usha Datta, Professor C.K. Banerjee, and Professor Gurjeevan Garewal. I should also particularly mention Professor and a good friend of mine, Kanjaksha Ghosh, who is also
in the audience today. Today, I would like to present to you all a relatively new entity in hematology, which has some unique, challenging underpinnings, and importantly, to recognize this blossoming field in hematology and to highlight the research opportunities that are available for younger hematologists and pathologists in this area. You will get a glimpse of the discovery of this entity, its cross-disciplinary implications, especially cardiovascular, and the genesis and biology of this disorder. You will also hear about its clinical relevance and the possibility of cancer prevention being applied to this entity, similar to the successful approach of chemoprevention in solid tumors, notably breast and colon cancer. This prevention angle was the reason for my choice of this topic for today's oration, for it is cancer prevention or chemoprevention research that engaged my academic career for the last 30 years, and I thought it would be an appropriate topic because clonal hematopoiesis, as you would see in the slides ahead, is a precursor lesion for hematological malignancies, and chemoprevention is a rational approach, albeit with clinical challenges. So what is clonal hematopoiesis? Clonal hematopoiesis is a dynamic and newly recognized phenomenon. It's the acquisition of somatic mutations in hematopoietic stem cells. An acquisition of these somatic mutations over time transforms normal polyclonal hematopoiesis to a skewed clonal hematopoiesis. So what happens to these mutated cells? These mutated cells confer a selective advantage and lead to expansion of this mutated cell pool. Mutant clones have enhanced proliferative potential. They disrupt critical regulatory pathways and provide what is called clonal fitness advantages. Mutated cells outcompete normal cells and change the cellular composition of the bone marrow. At the core of today's discussion on clonal hematopoiesis lies two important fields of cosmic proportion in hematology: clonality and hematopoiesis. Clonality is a fundamental defect established in many myeloid and lymphoid neoplasms long before next-generation sequencing was discovered or used. The application of X chromosome inactivation and G6PD polymorphisms, the use of microsatellites and other gene markers of cell origin established clonality in many myeloid and lymphoid neoplasms. Shown here is a seminal contribution from Philip Fialco and his co-workers to the origin and development of malignant hematopoietic disorders. This example being chronic myeloid leukemia, where through G6PD polymorphism and X chromosome inactivation, Philip Fialco was able to show that chronic myeloid leukemia is a clonal disease. The second way to establish clonality that was applied was the Humira clonality assays. And shown here are an example of a Humira clonality assay published in Blood 1996. What it shows is skewing of the X chromosome and a disturbed allelic ratio seen in normal individuals, suggestive of an abnormality within the cell. If you look at the electrographs here, you would see that as you get older, more than 60 years, the skewing increases compared to the younger people in the age group lesser than 60. So this happens in normal individuals, and the skewing was considered and described by the authors as probably an evidence of clonal hematopoiesis. This was published in 1996. But then things went quiet for a long time. And I will show you in a few slides the discoveries that were identified with next generation sequencing. The stem cell properties are important to understand up front in understanding this disease. Stem cells are known for self-renewal. They're capable of differentiation. They are usually quiet. They have a maintenance program, but they can be activated by inflammatory cytokines and regenerative signals. And stresses cause functional decline and impaired self-renewal and exhaustion. And deregulation causes loss of functional integrity and can sometimes progress to malignancy. So in 2012, for the first time, next generation sequencing was not available, but somatic mutations were looked at in women with skewed X-linked inactivation, and 10 women were found to have TET2 mutation. But in 2014, 3 groups looked at a total of 30,000 persons for mutations that were known to be commonly seen in hematological malignancy by whole exome sequencing. And they discovered a restricted set of mutations in these individuals who were normal. They had normal blood counts. Age-related increase in prevalence of this condition was noted. And the genes known to be mutated in hematological malignancies was seen in normal individuals and was particularly related to age. So as you got older, you found more of these mutations. The findings from these studies opened up a whole new area of hematology with far-reaching implications, as you would see in the subsequent slides. The mutations were restricted to a few select genes involved in DNA methylation, chromatin regulation, and splicing factors. So these were the 3 seminal papers that opened up this field, published by Genovese et al., Shi et al., and Jaiswal et al. And all of them had a common theme: age-related increase in clonal hematopoiesis in normal individuals, characterized by a select set of genes with an increased risk of cardiovascular disease and increase in all-cause mortality. These were surprising features published by these authors. The cardiovascular disease, of course, threw everyone off, and no one was able to explain the reasons at that time. So these are representative figures to show the age-related prevalence of clonal hematopoiesis from the 3 publications. If you look at the commonly mutated genes, the commonly mutated genes are outlined here. They include DNMT3A, TET2, ASXL1, Pgi-Hem-Onc, and TP53. The purple graph line that stands out there is because there was an overrepresentation in that particular paper of patients who received chemotherapy or radiation, and those patients were prone to have Pgi-Hem-Onc or TP53 mutation. The frequency of these mutated genes in clonal hematopoiesis is outlined here. The numbers next to the gene shows you the percentage. So when you look at these mutations, there are passenger mutations and driver mutations. Several mutations occur during the aging process of passenger mutations and occur in the non-coding region. There are also several mutations of these genes that land at the right spot, referred to as the usual suspects. Epigenetic genes such as DNMT3A and others outlined in the slide are the most common. Older individuals more than 70 years have stem cell mutations marked by spliceosome mutations such as SF3P1 and SRSF2. Other genes mutated are also mentioned here. Cellular damage is the underlying common determinant of aging and cancer. Cellular damage is due to loss of diversity and plasticity and functionality of the aging hematopoietic and immune system. Age influences the prevalence of these driver genes. And within the gene group, DNMT3 mutations show no relationship with advancing age, whereas there are other mutations which are related to advancing age. Some of these mutations cause the clones to grow very fast, whereas some of the genes do not do that. Somatic mutations cause clonal expansion and clonal fitness by positive selection. Clones with sufficient fitness evolve and acquire clonal dominance. Fitness is governed by cell intrinsic and cell extrinsic factors. Mutational diversity is influenced by environmental factors. I have mentioned some of the environmental factors that may lead to mutational diversity. The types of mutations in clonal hematopoiesis are the following. Apart from the somatic mutations, you can have loss of Y chromosome or mosaic chromosome abnormalities, which for a long time was ignored. But now we know, after the discovery of somatic mutations by next generation sequencing, that mosaic loss of Y chromosome and mosaic chromosome abnormalities or chromosome alterations are also important in the pathology of some diseases and not to be ignored. For example, it has been noted recently using large databases, this one particularly from the UK Biobank, that mosaic chromosome abnormalities can cause individuals to be susceptible to increased infection, poor immunity, an increase in hematological malignancies, increase in cardiovascular-related death in cancer survivors. And the same applies to the mosaic loss of Y chromosome. Many of us in practice in hematology, when you do a bone marrow, occasionally you'll find a normal bone marrow, but with loss of Y chromosome, which was largely ignored over the years. But today we have data which say that the loss of Y chromosome is associated with adverse outcomes like shorter lifespan, age-related diseases, and perhaps some malignancies. The next few slides, I'll try to show you what happens to this mutated clone. So one thing it does, it has to expand and be able to perpetuate itself and proliferate. So how does it do that? What are the mechanisms? A mechanism is suggested in this paper from Margaret Goodell's group, published in Blood, where if you look closely at figure C, you will see that every alternate cell division, it takes on an extra cell in the green channel, which is the stem cell, rather than following what is seen in the A channel. And at the end of the day, you end up with more greens than there are yellow. So there are more stem cells. And that's how the stem cell pool expands. A bias towards self-renewal, an imbalanced cell division. Hematopoiesis is a highly efficient process and goes on for several decades. But the erosive effects of aging and the acquisition of somatic mutations leads to clonal hematopoiesis, the so-called age-related clonal hematopoiesis. A narrow set of genes confer the ability to expand in stem cells. Mutations drive faster clonal growth, carries higher risk of malignant progression, which is depicted here. Somatic mutations in clonal hematopoiesis is a lifelong process. Clonal growth is determined by specific gene mutations. Somatic mutation, surprisingly, begins in early life, even at infancy. And most somatic mutations seen in clonal hematopoiesis exhibit a constant rate of expansion. So these clones take more than 30 years from its origin to reach a detection level with a frequency of 2%. The growth and expansion rates of these clones vary, and it depends upon the genes that are mutated. For example, DNMT3A and TP53 mutated clones are slow and grow at about 5% per year. TET2 and the other genes mentioned there grow at around 10% per year, whereas SRSF2 and U2AF1 are clones that grow at a faster rate. These are important to realize and understand, as you will see in the subsequent slides, that when we come to predicting how or which of these patients may progress rapidly to malignancy, these factors may be of importance. Mutations, as mentioned earlier, begins in early life, and they accumulate over the lifetime of the individual. The stem cells differ in characteristics as individuals age. Expanded clones can be detected in middle age by more sensitive techniques of whole exome sequencing or next generation sequencing. This mutation or somatic mosaicism occurs in a variety of tissues as shown here, but we are focused today on the bone marrow, but it happens even in other tissues. If you look at their evolutionary pattern over time, following it up over an extended period of time, you will see that their different genes have different trajectories of growth, with JAK2 and U2AF1 and the SRSF2s growing faster than the slower genetic mutations. An important paper was published in Nature this year. And basically what this asks is, we know that the rate of mutation acquisition in stem cells appears to be constant. If that is the case, are there individual factors that drive expansion of these chip clones in select individuals? Another question regarding clonal expansion was whether intrinsic genes would function and influence clonal expansion. This study from Weinstock throws some light on this concept. What happens here is TCL1A is a gene that is normally repressed in hematopoietic stem cells, but is expressed in B cells and in plasmacytoid dendritic cells. When these stem cells acquire somatic mutations, i.e. TET2 or ASXL1, then this TCL1 can get expressed. Now in experimental data, those who have expression of TCL1A, the cells grow faster and are fitter than those who do not have that. This has been demonstrated by knockout experiments of TCL1A in experimental mouse models. So TCL1 expression may play a role in stem cell adaptation to the aging bone marrow environment and marrow stress response. I believe over the next several years, we're going to find more genes that are operative in this condition. Genetic variants also determine distinct diseases. And I have given you a list of these diseases. DNMT3A has a strong association with osteoporosis. DNMT3A is not associated with significance with heart failure. TET2 and JAK2 are strongly associated with cardiovascular disease. TET2 and PPM1D mutations are associated with a higher risk for vascular events and death after ischemic stroke. And I will show you what is the postulated mechanism for this in a few slides. These are clonally restricted mutations that are seen in particular clinical settings that may be important. I would like you to focus on aplastic anemia to drive home the point that these genetic mutations may have an effect on therapeutic outcome. Aplastic anemia patients with certain mutations other than Pgi, BCOR, or BCOR-L1 have a poorer prognosis and higher rate of evolution to myelodysplasia or acute myeloid leukemia, and lower response to anti-T cell immunotherapy. JAK2 mutations is associated with an increased risk of arterial and venous thrombosis. Recently, additional genetic loci that are inherited have been discovered. And why is that important? Because the inheritance of these genes may play a role in the progression of clonal hematopoiesis. This study by Carr et al. Show that certain genes predispose and certain genes protect against certain types of clonal hematopoiesis. Again, the study was done with data from the large UK biobank recently. In summary, inherited variants of germline genetic loci predisposed to clonal hematopoiesis. The association is either a predisposing factor or protective. The genetic predisposition to clonal hematopoiesis increases risk for non-hematological neoplasia, atrial fibrillation, and epigenetic aging as well. Clonal hematopoiesis causes alterations in inflammation. Inflammation influences clonal hematopoiesis. And maybe the driving force, as shown later, for the onset of atherosclerosis in clonal hematopoiesis. The bone marrow microenvironment and its alteration can also play a role in changing the signature behavior of these clonal hematopoietic cells. So does the intestinal microbiome balance. Intestinal microbiome normally produces short-chain fatty acids, which are key factors in host metabolism and immunity maintenance. So here comes a stepwise progression model of clonal hematopoiesis. As you can see, just like in solid tumors, these clonally mutated cells moves through several steps: early events, late events, selective pressures that include inflammation, marrow microenvironment, lifestyle, and they progress over time, release inflammatory molecules, clonally expand, and can cause hematological neoplasms. Myeloid clonal hematopoiesis is the commoner of the two types of hematopoiesis, but there is also lymphoid clonal hematopoiesis. And lymphoid clonal hematopoiesis progresses to a whole new, different set of disorders, including autoimmune diseases, lymphoid malignancy, and immunodeficiency, while myeloid clonal hematopoiesis causes myeloid malignancy, cardiovascular disease, and increased mortality. Several other non-hematological complications or associations have been discovered in individuals who have clonal hematopoiesis that is outlined here, including venous thromboembolism, type 2 diabetes, COPD, osteoporosis, and gout. Now, Alzheimer's disease is actually, the intensity of Alzheimer's disease is improved, ironically, on patients who develop clonal hematopoiesis. The exact explanation for that difference, why Alzheimer's disease is, the patients are protected from Alzheimer's disease by clonal hematopoiesis, is not very clear. But the theory is the microglial cells get activated by the mutation and they engulf the abnormal proteins that are responsible for Alzheimer's disease, though it's not been amply proved as yet. But the fact that Alzheimer's disease may be less in patients with clonal hematopoiesis, there are more than one publication to establish that. So, how does clonal hematopoiesis impact hematology? Clonal hematopoiesis is now established as a precursor condition to hematological malignancies. It is now included in the WHO 2022 classification and in the ICC, the International Consensus Classification. The term CHIP refers to clonal hematopoiesis with a cancer-associated somatic mutation that is detected in the peripheral blood at a frequency of more than 2% in the absence of a hematological malignancy or unexplained cytopenia. CHIP associated with cytopenia is called clonal cytopenia of undetermined significance. And then we have two other diseases with disturbances of monocytosis and monocytosis with cytopenia. This is the definition of CHIP, which has been incorporated in the WHO. So for hematologists, the conditions that one has to grapple with is depicted here. And the features that make the distinction are clonality, dysplasia, cytopenia, bone marrow blast, cytogenetic aberration, molecular aberration, and the risk of progression can be calculated. We still learning on how to manage patients with clonal hematopoiesis. This is a simplified pathway as to what one could do if you have a patient in your clinic with CHIP. Much of it is just observation. We still have no active intervention that has been published or standardized. So the identification of negative outcomes, cardiovascular mortality, was a surprise, as I had indicated earlier. A powerful, previously unrecognized an independent cardiovascular risk factor lies at the interface of aging, heart disease, and cancer, clonal hematopoiesis. All three mutation types associated with clonal hematopoiesis have been linked with increased risk of cardiovascular disease. As you would see, the risk of cardiovascular problems is 1.5 to 2 times and nearly 4 times the risk for myocardial infarction. The risk is dependent on cohort size and healthy volunteer bias in the UK Biobank, and is independent of the standard risk factors for cardiovascular disease, including smoking, cholesterol, obesity, and others. So this is a strongly or fiercely independent risk factor. Several publications have come forth demonstrating the effect on outcomes from a cardiovascular perspective when patients or individuals have clonal hematopoiesis. As shown in these graphs here, you'll see that the atherosclerotic cardiovascular events, the all-cause mortality, are significantly different in those patients or individuals who have clonal hematopoiesis, as seen in red, compared to those patients or those individuals who do not have these mutations, as seen in blue. These observations from large biobank databases has been corroborated with experiments in the laboratories. For example, transplantation of TET2 deficient bone marrow into the LDL receptor deficient mouse accelerates atherosclerosis via pro-inflammatory macrophages. Mice transplanted with TET2 deficient bone marrow exhibit poor cardiac remodeling in heart failure models. Transplantation of TET2 deficient bone marrow into non-irradiated wild-type mice increased cardiac fibrosis and hypertrophy. Again, clonal hematopoiesis influenced heart failure outcomes, and the key mutations were TET2 and DNMT3A. Poorer survival, higher hospitalization rates, reduced ejection fraction, and accelerated heart failure progression were documented in these individuals. If you look at this diagram, it shows you that the mutated cells will release cytokines and pro-inflammatory T cells and neutrophil inflammatory molecules that causes increased risk of atherosclerosis, poorer outcomes in aortic stenosis, accelerated heart failure, and enhanced thrombogenesis. Clonal hematopoiesis also increases the risk of ischemic stroke. And a particular marker of the interleukin pathway was implicated in one publication. And a germline variant of the interleukin 6 receptor was known to mitigate this increased risk. So these were all surprising new findings that took this data and this disorder to other fields other than hematology. This is a diagram of possible ways to intervene to reduce the risk of cardiac problems, targeting interleukin 6 or TNF alpha, interleukin 1 receptor, and so on and so forth. Such studies are in clinical trials and underway in lead centers in the United States. So what are the risk factors for clonal hematopoiesis? Many factors determine risk of malignant transformation, which I have explained earlier. Risk factor exposure, chemotherapy, obesity, tobacco, radiation, some inherited germline variants, fitness advantage, the high-risk mutations, they all play a role in the evolution of this disease. So one of the challenges in clonal hematopoiesis we have identified over the years is that the risk, overall risk of malignant transformation is not very high. But the risk is high in a particular groups of patients with clonal hematopoiesis. So these authors from the Dana-Farber Cancer Institute studied these mutations and correlated them with other factors to determine if there is anything that can predict or help with a scoring system that would help to determine those who may be at high risk. That way we could remove those patients with low risk with clonal hematopoiesis from intervention because their risk is so low. And these authors were able to create a risk score, what they call a clonal hematopoiesis risk score, using the criteria that are outlined in the left table to evolve a scoring system with those categories of low risk, intermediate risk, and high risk. The 10-year risk of malignant transformation in the low risk is very low, less than 1%. The 10-year risk in the high risk, though, is very high, 50%. So this helps with categorizing those who may require intervention at an early stage and allow those who have low risk to be and lead a normal life. There are some other benefits of clonal hematopoiesis. It's been noted that adjuvant therapy in colorectal cancer, there seem to be better efficacy in those patients with clonal hematopoiesis. The CAR-T CR rate may be better in those with clonal hematopoiesis. The pathophysiological mechanisms behind these effects are still being studied and unraveled, hopefully. Now comes the next important topic. Can we prevent the clonal hematopoiesis from progression? An important concept, but filled with challenges. The cancer prevention or chemoprevention approach in clonal hematopoiesis would be similar to the approach that we have used successfully in chemoprevention trials of breast cancer, colon cancer, and others. These are being addressed and these are being studied in trials. The trial design, the endpoints, how do you stratify these patients? How do you identify the high-risk groups? What are the targets and what are the pathways? Are all challenges that needs to be worked out. Some centers in the United States have what they call CHIP clinics. Harvard, Massachusetts General Hospital, and Sloan Kettering have these CHIP clinics. And the Mayo Clinic has that too. These are patients with clonal hematopoiesis who are studied in these clinics. They require expertise from genetics specialists, cardiovascular specialists. We have to iron out the economics and logistics of DNA sequencing, the patient volume, combining these patients with other pre-cancer conditions in hematology like MGUS or monoclonal B-cell lymphocytosis. And in America, billing and coding considerations all have to be ironed out. This may be too small for the audience to see, but I'm just going to pick one example of how this may be important in day-to-day practice. For example, if you have a non-germline TP53 variant mutation, with a frequency of more than 30% in a breast cancer patient just before receiving adjuvant therapy. These patients, if you subject them to traditional chemotherapy, has a much higher risk of hematological malignancy. So knowing the mutation in a patient with breast cancer before adjuvant therapy in that context, it's important to discuss with the patient what they would choose to do, whether they would like anthracycline-based adjuvant chemotherapy or whether they will choose not to. There are many sources of referrals that one would have to battle with in the future in this condition. Clinical trials are also ongoing in the combination of cytopenia with clonal hematopoiesis, what we call CCUS. And correlative studies are also being arranged or being conducted. What have we learned? So this fascinating entity is at the interface of hematopoiesis and systemic diseases. It's increasingly recognized as a risk for clonal progression and cardiovascular morbidity and mortality. The role of genetic factors in the mechanisms of clonal expansion and dominance is being better understood. The management of affected patients beyond blood count monitoring and control of cardiovascular risk factors is being actively explored. It's an independent risk factor for cardiovascular disease, and targeting the inflammatory pathways may have a role in the management of this disease. Large prospective cohort studies in clonal hematopoiesis should provide insights into natural history and progression of this disease. The effects of intervention on non-hematological conditions needs to be worked out. Urgent need to streamline our approach to clonal hematopoiesis and hopefully develop standard guidelines for the management and identification of high-risk subgroups is urgent. Resource-limited settings will have to plan a fiscally feasible and practical approach to the handling of this entity. Hematology clinics will expect to see an increase in referrals from several sources with this condition for their opinion in the future. Thank you.
Thank you, sir, for that superlative talk. It was indeed a privilege for us to be a witness to this oration. And I'm sure that we are all now wiser and will look upon clonal hematopoiesis in a very new light. May I now request our director, Professor Vivek Lal, to felicitate Professor Krishnan with a memento. I now request our Dean, Professor Naresh Panda, to felicitate Professor Krishnan with a shawl. May I now request our Dean, Professor Naresh Panda, to deliver the vote of thanks, please.
Good afternoon. Professor Vivek Lal, Director PGI, Professor K. Krishnan, the orator for today's Dr. B.K. Aikat's oration, Professor Radhika Srinivasan, Chairperson of the Department of Pathology, Professor B.N. Datta, former Dean, PGI, Professor Shobha Sehgal, Professor Deepika Mahanti, Professor Gurjeevan Grewal, Professor C.K. Banerjee, Professor Usha Datta, former heads of departments of pathology, Dean Research, Professor Ratho, Medical Superintendent, Professor Vipin Kaushal, Financial Advisor, Mr. Gaurav. Thank you very much. First of all, it's my pleasant privilege to offer a vote of thanks to one of our own, Professor K. Krishnan, who is an alumni of our institute. Sir, it gives us a great joy and pride that you have made a name for yourself. You have done so well, and that is that you have kept the PGI flag fly high. Thank you very much. With the presence of so many who's who of pathology, like they say, infection is contagious. I'm sure the presence of so many senior people from pathology will be really inspirational and contagiously inspiration for the young students who are doing their pathology training here. So thank you very much, everyone, and thank you very much, ladies and gentlemen, for having graced this occasion and come for this oration. Good evening.
Thank you, Dean sir. With that, we come to the end of the 12th Professor B.K. Aikat Memorial Oration. I invite you now all for a cup of tea at the lawns behind. Thank you so much. There is one announcement before we break for the conference. There is a poster evaluation going on in the Zakir Hall right now. And for interested people, there is a parallel session in the Advanced Pediatric Center on managing infections in hematological malignancies starting at 6 p.m. And I also invite everyone back to the auditorium at 7 p.m. for the cultural program, please.
Can I just request the PAT department, faculty and residents to occupy the red seats just for a small group photo? Please occupy the red seats behind our teachers.